and triple negative. But first, I'll try to go a little bit history, because why immunotherapy really work in triple negative, and how things moved from an earlier stages of clinical trial, phase 1, phase 2, into phase 3 clinical trials, and then how to choose those patients who benefit the most from immunotherapy, and where we are heading when it comes to immunotherapy era in triple negative disease. And that's probably what I'm going to go to today. So definitely triple negative is an aggressive disease. It's really representing 15% of our patients. We still to ignore those who are low ER, PR positive, because they are also endocrine resistant. They behave the way as triple negative, and most of the time we treat them the way we treat triple negative disease, and that's something we have to keep in mind. So why immunotherapy work in triple negative? Why this subtypes in particular? If you look for triple negative disease, you will find that triple negative disease have more high mutational burden, and this is really something has been encountered with triple negative compared to other classes or other subtypes like hormone positive, including HER2 also positive. So this is maybe one of the reasons why immunotherapy really work in triple negative. But the question is that enough? Does immunotherapy work in all subtypes of triple negative disease? It's not really the case, because triple negative is quite complex biology. If you go with from a molecular perspective, there are different molecular subtypes, starting from a basal, where there are more immunosensitive disease, into the extreme, where we see the luminal disease, and something also in between the mesenchymal and so on. So there are quite difference in the biology of the triple negative disease. It's not just high the mutational burden, but also there are group what we call them immune rich, and there are also a group with our immune poor subtypes, and that's maybe another way to help you to make a decision how those patients really benefit from immunotherapy if they are triple negative disease. So how to prove this in real life? You start with the clinical trial. And if you go back to the clinical trial in the earlier stages, this is probably one of them, ASCO presentation 2017, showing the earlier data for immunotherapy in triple negative. And it was kind of a single agent monotherapy for those who have been heavily pre-treated, those who have received everything, and then they got immunotherapy as a monotherapy. What's really interesting to see here is the response is really modest. It's not even modest. It's less than 10% with the monotherapy for those who are heavily pre-treated. But as with other clinical trials, you'll see that there are still some group of patients who have not received any systemic therapy before. And if you look at those patients in particular, you will see the response rate is higher. And this has been seen also with the same smaller phase 2 clinical trials. We may not see much response rate with the monotherapy in heavily pre-treated, but we have seen it higher with pre-treated patient or previously untreated patient. And if you also include those with high PD-L1 or those with PD-L1 positive tumor, you may get the best response with the monotherapy. Is this enough? Still, it's modest. Even 20% response rate in a triple negative, I would call it also modest. This has been also seen with different phase 2 clinical trials, and you can see the difference in the response rate between those who have received immunotherapy as monotherapy. Here it's just a monotherapy. You can see the responses in the 20s for those who have received treatment in a first line, providing they are PD-L1 positive tumor, compared to those who have received it in the second line, where the response is even less than 10%. What has been also seen, if you use it in a high PD-L1, in a PD-L1 positive tumor in the first line, is not just the response rate is higher, but also the duration of response is longer. And that's also correlated with the survival when they looked at the longer follow-up. And this has been seen with the longer follow-up from those phase 2 clinical trials. Those observation is really make everyone think is, okay, so the response rate is 20%, is still modest. How to improve that? And that's from there the concept of combination came on. This is one of the earlier data that I've addressed the role of chemo combination, because chemotherapy is still the cornerstone in triple negative disease, how the chemotherapy really work in combination with immunotherapy. And this is one of the earlier data. initially with Atezo, then Pembro, and you can see the response rate increased from a 20 into a 30, 40% if you just add chemotherapy for those patients who received who have not received systemic therapy, and the response rate is really high, especially if you use it in a first line, not second line. Still, even with the combination approach, you can see the response is higher in the first than the second line. And from all those clinical trials, the concept of first line, the concept of combination is led to development of many clinical trials addressing this particular group of patients. And here we have, this is kind of, I would say, the most important phase 3 clinical trials, that address the immunotherapy combination in the first line for triple negative disease. The story started with Compassion 130, which addressed Atezo plus nab-paclitaxel. Then we have the 131, which addressed the same regimen, but with a different backbone, which is most widely available, which is the paclitaxel. Then we have the Keynote 355, which also addressed the chemo combination with checkpoint inhibitor. Here was Pembro, and this is probably the standard of care that we have right now. We also have the Compassion 132, which address two different concepts. First, the earlier relapser, but also the different chemotherapy backbone, which is the platinum. And also we have one from the Far East, which is the Torchlight, addressing the toripalimab with the taxane. This is maybe the important phase 3 clinical trials. The first one, and the proof of concept, in fact, came from the Compassion 130. This is the trial that really proved the concept that the chemo immunotherapy work. As you remember, the design here is chemo, and the chemotherapy was nab-paclitaxel. The checkpoint inhibitor was atezolizumab compared to the chemotherapy alone. And you can see here the benefit was seen in the BFS and the survival. However, the benefit was limited to PD-L1 positive tumor, and there are different platforms has been assessed in all those different trials. Here they use the SP142 in the tumor cells, but if you look at them, the BFS is longer for PD-L1 positive tumor, and this has translated into the survival difference. This trial have changed the practice of care at that time, but the adoption of this trial was not widely available because simply for one reason, because nab-paclitaxel was not available everywhere. This is one of them critique of this trial, and they try to also work on that by changing the regimen or changing the chemotherapy backbone, and this was the platform for the Compassion 131, which is exactly a similar trial. It's atezolizumab with the traditional chemotherapy that we are using in our practice, which is the paclitaxel or nab-paclitaxel. But what's quite disappointing here, though, it was similar design, is the result that has been seen in 130 was not seen in 131, and there was no clear difference in the PFS nor into the survival, and that's why this have created a lot of concern, not just in this trial but also in the same regimen, and that's at some point have led to withdrawal of even the Compassion 130 from the US, but still it's available or approved in the Europe. Then we have the Keynote 355, which is also a trial that addressed the chemo immunotherapy combo. There are a few important differences in this trial, apart from the checkpoint inhibitor that has been used, which is the Pembro. But the chemotherapy here is kind of wide spectrum. It's nab-paclitaxel, it's a paclitaxel, as well as the carbogem. So it's most of the chemotherapy regimen that we are using. There is other important difference, if not sure if it was clear here, is the time or the recruitment of those patients, or those who have shorter relapse, less than 12 months, from 6 to 12 months were included in this trial compared to the Compassion 30. The trial was positive, and that's also not in everyone, but also for the PD-L1 positive, defined as the CPS score of more than 10. Here they use the combined score, which is a different platform that we have from the Compassion 30. The benefit was clear in the BFS. The BFS was longer with chemoimmunotherapy compared to chemotherapy. Also, the survival was also longer. There was almost difference, around 7 or 8 difference in the survival. The benefit was seen across different chemotherapy regimen, even in whether nab-paclitaxel or paclitaxel. It might be a little bit smaller with the platinum gem, but it was explained at that time because the platinum gem, we use it only for the short relapser. It's not about the chemotherapy, but maybe the biology of the disease, but it was consistent benefit across all those regimen. And this was the trial that led to adoption of chemoimmunotherapy in a triple negative in the first line for the PD-L1 positive if they have CPS score more or equal to 10. We have also a follow-up trial for the IMPassion, which is 132. And this trial is addressed two concepts. The first concept is what about the short relapser, those who less than 12 months, including even within the 6 months, and also address the other chemotherapy regimen that we are most of the time use it for the short relapser, which is the platinum combo. The result was also similar to IMPassion 131, and was shown no additional benefit. Is it have to do with checkpoint inhibitor or maybe with the disease biology, including the short relapser, which I think is have to do with the short relapsing disease more than the drug itself. There's also another trial. This is from the Far East, looking at toripalimab, which is a common drug available in China. This is the trial addressed combination of toripalimab with taxane, with the nab-paclitaxel, and the result was positive. It's similar to what we have seen with other trial of chemoimmunotherapy in the like KEYNOTE or IMPassion 130. We have seen also clear difference in the PFS. And those benefits are mostly driven, not sure if you can see that, but it's driven in the PD-L1 positive tumor. And also we have seen a clear survival difference, mostly pronounced in the PD-L1 positive tumor. And that has been adopted as an option in the China because that's where the trial has been designed and recruited. The ADC has been discussed with Dr. Essam, and I think that the rationale has been also well described, and I think it's similar to what we have with chemotherapy. With more cancer cell death, there will be more antigen release, and that's maybe an environment for addition of immunotherapy for those functional immune activated tumor cells. But the concept behind this combination also has been addressed in a phase 1 or phase 2 clinical trial. This is one of the earlier clinical trials that have addressed the concept of combination of ADC with immunotherapy. First was the Begonia trial, and then we have the Morpheus trial. All of them have addressed different ADC, the Dato with Durva or the SG with the Tizo. What's quite consistent among those trials is the response rate is high, and it was reached to 70, around 70% in both of those trials, and that was enough to support designing a phase 3 clinical trial that has been also addressed earlier by Dr. Essam. I will just go with an ASCENT-4 or the KEYNOTE 19, which is the trial that addressed the chemo or ADC plus Pembro versus the chemotherapy Pembro in the PD-L1 positive tumor, the CPS score of those with high CPS score disease, and that's was quite significant when it comes to the BFS. The BFS was longer from 7 to 11, and that was clinically and statistically significant. We have seen the survival, but it's still immature. There was kind of a trend has been seen with the descriptive analysis that has been presented in last ASCO. And it's also important to point out also the response rate was high, reaching to 60. There was more complete responder. And it's not just the response rate, the duration of response. And I think that's really important when it comes to triple negative, because whatever response you achieve might not be durable. And if you have a more durable response, this might impact also in the survival at some point. What's really coming in the future is the bispecific, which is, I think we start to see those data are coming from different disease, and triple negative is one of them. there was earlier study has been presented at San Antonio, I think this year, not 2023, and that's about bispecific antibody, which is targeting both PD-L1 and VEGF at the same time. And they try to address this with combination with chemotherapy in those patients with a triple negative who received, who have treatment naive, and the response rate was kind of 80%. And there are many ongoing phase 2, phase 3 clinical trial, has been also planned to address this drug or those bispecific antibody, which I think we start to see many of them in the phase 3 clinical trials in different disease and triple negative. In fact, there was 2 or 3 addressing the same concept. This is have formed the guidelines. If you look at the ISMO, which also has been shown earlier, and you can see that still the chemoimmunotherapy or the chemo-pembro is a standard of care for PD-L1 positive tumor. Still, atezo is one of the options when you look at the European guideline. But if you go to the NCCN, if you just focus on the PD-L1 positive, which is the first box, first line, you'll see that there is a number of options, including the chemoimmunotherapy, whether paclitaxel or not paclitaxel, but also they include SG plus pembro, though it's written here as a preferred, not a level 1 evidence, and I assume that because we don't have regulatory approval, maybe the follow-up survival will add depth to this indication. With this, I think, so the take-home message from this, no doubt that first-line PD-L1 positive tumor metastatic triple negative is, I think this is where we have the immunotherapy combination. Standard of care still chemotherapy, but I think we are moving to ADC immunotherapy for PD-L1 positive tumor. The chemotherapy backbone might impact on the result, choosing the PD-L1 status and the level of PD-L1, and the assay might also impact. ADC IO is really a preferred now in the guidelines, and maybe it would replace the chemoimmunotherapy in near future. With this, I think I reached the last slide.
Always, my pleasure to introduce the next speaker, Dr. Amin Al-Tijani, consultant of medical oncology at Prince Mohammed bin Abdulaziz Hospital, Ministry of National Guard and Health Affairs at the Medina Munawwara, Saudi Arabia. He will give us a talk about the management of IO toxicity and immunogenicity.
First of all, I would like to thank the organizer for inviting me to participate in this meeting. Special thanks for Dr. Nafisa Abdel-Hafiz and Dr. Mohammed Al-Barni. And also, I want to congratulate them on this continuous success. Also, my thanks to Dr. Ali, Dr. Bassam for chairing this session. So my talk will be about the management of toxicity from immunotherapy. So immunotherapy-related adverse events can affect any organ of the body. The onset varies. Actually, it can be usually from 2 to 3 months, but it can be up to 2 years after the end of the treatment. You need to have a high level of suspicion for diagnosis, and if there is any new symptoms, so we will consider this may be due to the adverse events, and we need to do a complete workup by blood test and radiological. There is no current way to predict who will develop these adverse events, which is different from other treatment, anti-cancer treatment, like chemotherapy and other targeted therapy. When we compare the toxicity with immunotherapy with those with chemotherapy, we can see that the incidence for chemotherapy is almost all patients might be affected. Immunotherapy, the majority, they did not develop any side effects. The profile is well described in chemotherapy. You know that in myelosuppression and alopecia, myopositis, all of these can happen with chemotherapy. Immunotherapy is very therapy, but it is variable with immunotherapy. So the bottom line, chemotherapy is predictable. The toxicity for immunotherapy, it is, we can say, relatively unpredictable. We know that the checkpoint inhibitors enhance the T cell activation by blocking the PD-1, PD-L1, and CTLA-4, and this leads to autoimmune toxicity, which can be organ-specific or general, affecting skin, GI, liver, and lungs, and also endocrine. And the corticosteroid actually work to restore this immunotolerance. The safety profile of immune checkpoint inhibitors, the most common side effects maybe from the gastrointestinal and skin toxicity. And we have also some special type of toxicity like colitis, pneumonitis, hepatitis, and also thyroid dysfunction. But we can see in this graph, most of these are low grade, grade 1 and 2, and grade 3 and above. This is mainly with the combination of adding anti-CTLA-4. When we look to the phase 3 triple negative trials with checkpoint inhibitors, we can see here the incidence of immune-mediated adverse events. Mainly it is endocrine and also dermatological toxicity. And for the endocrine, we can see hypothyroidism here predominate, then hyperthyroidism is also can be affected. But we went see that those who requiring steroids, the immune-related mediated adverse event requiring systemic steroid, so we can see there is low number or low percentage of those patients need systemic steroids. This is in the chemoimmunotherapy trials, and this is specifically in the Keynote 522. In the neoadjuvant phase, we are mainly seeing toxicity from chemotherapy. It is not from immunotherapy, but in the adjuvant, on the same trial, we can see the adverse events mainly from immunotherapy because patients receive immunotherapy in the adjuvant. Again, I will see this toxicity mainly lower grade, and the higher grade is a small number of patients. This is for immune-mediated adverse events also combined in the same trial, and show that this for any grade about 43.6%. For those who receive the combination chemo and immuno, for those who receive only chemotherapy, it is about 21.9%. Grade 3 and 5, about 15% for the combination with immunotherapy, and only 2% for the placebo. And those led to discontinuation, 11% for the combination, and like 2.6% in the placebo arm. In the adjuvant setting, we can see lower grades, mainly 10.2 in the any grades, and higher grades is only like 3%, and those led to discontinuation only about 1.4%. The timing actually can be highly variable, and we can see here skin toxicity and GI toxicity mainly occur earlier, like less than 2 months, and for the others, hepatic toxicity, endocrine, pneumonitis, this appears a bit later, but it can occur even months after the end of the treatment, and the time course might be even more variable with novel combination. The median onset generally like 1 month to 3 months after initiation, but definitely it can occur within days or after months of treatment, or even after stopping the treatment. The incidence and severity increases with the combination, mainly when we're adding the anti-CTLA4 agents. A high-grade adverse events with one class does not preclude safe administration of the another immune checkpoint inhibitor class. It is very important to do baseline assessments prior to initiation of the treatment, and history is very important, and this should include autoimmune disease, infectious disease, endocrine, bowel function, and other comorbidities. Patient education is very important about these events, and very important to tell our patient to communicate and to report any side effects. Counseling for steroids also is very important. Lab test is very essential to do. CBC, complete metabolic panel, liver function, thyroid function, and sometimes we need to do radiological assessment. Also, on treatment and post-treatment, we need also to do the assessment by blood test, including thyroid function test, CBC, kidney function, and liver function. Clinical examination also is important. And after the completion of therapy, also we need to monitor, because some of the patients can develop this toxicity even after we stop the treatment. It is very important actually to use the clinical practice guidelines for the management of these toxicities. So it is a multidisciplinary management and should be coordinated by the oncologist. But all other subspecialties should be involved, including GI, pulmonologist, endocrinologist, ophthalmologist, and the others. So the step of management, first we need to diagnose, and we need to grade these immune-related adverse events to rule out other differential diagnoses, and pre-immune suppression workup is very important. Then to select the appropriate immunosuppression strategy, especially for grade 2 and higher. And we need to actively evaluate those patients after 3 days, because if they are not responding, so we need to change the therapy. This is the general principles of managing. Education of the patient is very important. We need to let other health professionals to know about this toxicity, and we need to assess each cycle. We need to assess the patient up to 3 months of the treatment. This is important. Thyroid function, as I mentioned, and we need to have a low threshold for steroids, and we can use other biological agents. Most of these adverse events are reversible, especially with treatment with immunosuppression and steroids. And we can see here in this curves, the beginning and the end of curve actually indicates the median time to onset and median time to resolution, and the peak indicates the incidence of the immune-related events. Regarding the management, for the mild cases or moderate, which is grade 1 and grade 2, this is mainly should be treated on outpatient setting mainly. Symptomatic treatment needs to be started for all patients. For grade 2 and higher, we need to stop the treatment. And we need to start steroids. For grade 2, we start oral steroids. For grade 3 and 4, we need intravenous steroids. And most likely patient will be inpatient in these cases, grade 3 and grade 4. And also we need to refer to the subspecialties to manage the patient with us also. How to choose the best treatment? We know the first line is corticosteroids. Second line, we have multiple options. And the choice of the second line depend on the organ affected or the suspected mechanism of action. And the timing of second line depend on corticosteroid non-responses or refractory, or corticosteroid dependent, and also according to the organ and the severity of the side effects. There's some guideline for steroid therapy. We need to taper, definitely. Long-term therapy sometimes required, and rapid taper not advised, not recommended, which may result of recurrence and flare of these side effects. Monitoring blood sugar is very important because we are giving a steroid. Adrenal insufficiency, we need to also follow for that. Muscle weakness, and very important, as you know, we need to have like proton pump inhibitors for gastritis. We have sometimes opportunistic infection for those who have steroids more than 4 weeks, so it's better to have prophylaxis, and also fungal infection. Osteoporosis risk is high, especially for those patients who receive long steroid use. So vitamin D and calcium are very important. In this slide, you can see here the higher corticosteroid peak dose for treatment is associated with worse survival across tumor types. And in this analysis of 6 phase 2 and 3 randomized controlled trials for Ipi/Nivo, and about more than 800 patients, 90% of them received corticosteroid only, 9% received corticosteroid plus second line, and it shows that the higher corticosteroid peak dose is associated with worse survival. So it is very important to use corticosteroids wisely and as needed. How to choose the best treatment for corticosteroid refractory? This is according to the suspected driver of toxicity. And we can see in this table, for example, tumor necrosis factor alpha, infliximab, interleukin-6, tocilizumab, and the rest. And also we have other drug options like mycophenolate mofetil, IVIG, plasmapheresis, and methotrexate. So to choose the best treatment, this depends on the mechanism of action and the organ involved. This is some selected scenarios, like dermatological. We know they present with rash, pruritus mainly in the trunk, and sometimes they can affect extremities. For colitis, diarrhea is the main symptoms. Also sometimes vomiting. For liver, we have mainly elevation in the liver function test, pancreatitis sometimes, or increase in the pancreatic enzymes, the amylase and lipase, and the endocrine also, whatever, if it is thyroid or pituitary. This is the less common, pneumonitis, definitely presented with dyspnea, cough, fever, renal with elevated creatinine level, and electrolyte balance. Ocular can happen also with vision affection, neurological, cardiovascular, also, and musculoskeletal. So when we look to the fatal immune-related adverse event, we can see it is less than 1 to 1.2% generally. And the cases and fatality rates by class, we can see it here. And you can see myocarditis have very high toxicity, fatal toxicity rate. And we have also colitis, pneumonitis. And we can see this is mainly happening in the combination. When we combine CTLA-4 with the PD-L1, they have higher rate of mortality, and usually it occurs earlier in the course of the treatment. This is endocrine toxicity management, which is common, very common, and especially we see it in this phase 3 trials of triple negative. So thyroid function is important. We will exclude other causes. Most of the time in the thyroid toxicity, we need to continue on immunotherapy. For hypothyroidism, definitely we give L-thyroxine, thyrotoxicosis, beta blocker, and antithyroid. And after treatment, we can re-challenge those cases. Pituitary and adrenal also can happen, but usually with non-specific symptoms. We need to evaluate the cortisol, especially the AM and ACTH should be done to distinguish between primary adrenal insufficiency from hypophysitis. We need to start steroids, definitely, to hold the treatment, and we can consider re-challenge later after improvement. This is for dermatological, definitely according to the grade. mainly depending on the body surface area, less than 10%, 10 to 30%, and more than 30%, grade 1 to grade 4, and also the severity of the symptoms. And for grade 1, we will continue treatment. Grade 2, we will hold. Antihistamine can be given. Steroids also can be given. Grade 3 and 4, we will hold, and we will hold. We start systemic steroids. This is other workup for colitis, hepatitis, nephritis, pneumonitis. Most of these are more or less similar. It depends on the organ affected, but the treatment will depend on the grade of toxicity. For diarrhea and colitis, the same thing. We need to hold. We will consider loperamide, to give loperamide for this patient. Hydration is very important. For higher grade, we will give steroids. We will involve the gastrointestinal team to be on board if there is severe toxicity, and sometimes requiring admission, and even sometimes with ICU admissions. And as I mentioned, if there is no response to steroid, to move for second line. Hepatitis, we need to limit the hepatotoxic medication, eliminate alcohol abuse. Infliximab is contraindicated in hepatitis because it might cause further liver injury. And the treatment also according to the grade, but most of the cases of hepatitis, we will discover it with the labs only without symptoms. Nephritis, the same thing, encourage hydration, nephrotoxic drug, and use of contrast also. And we need to give good hydration. We will give steroids for grade 2 and higher. And if need for severe cases, we'll give IV steroids, and the patient will be admitted. Pneumonitis, which is uncommon pneumonitis, but it is potentially fatal. We need to exclude infection, and sometimes for some cases like disease progression, high dose steroids for grade 2 and more is important. Grade 3 and 4 permanently discontinue. IV steroids, additional immunosuppression might be needed, like infliximab, hospitalization of those cases, and avoid rechallenge, especially for grade 3 and 4. Pneumonitis, we will not rechallenge, but we can consider it for grade 1 and 2. These other hypophysitis, myasthenia gravis also can happen. So we need to evaluate patients with MRI brain. Myocarditis, which is fatal. Myocarditis, when happen, most of the cases will die. Myositis also an option. So myocarditis management, we need to confirm first. We need to discontinue the immune checkpoint inhibitor. Tailor management to response. High dose steroids, we will give IV methylprednisone is very important here. And then we will involve cardiology also in these cases. Sometimes some of those patients needs ICU admission to treat them. So by this, I will have my key take-home message. Immune-related adverse events are variable in timing and organ involvement, and this is mostly endocrine, dermatological, pneumonitis, colitis, and hepatitis. Early recognition is very important and critical. Corticosteroid first line for most moderate to severe. We need to start early. Efficacy of checkpoint inhibitors will not be affected. Prolonged taper sometimes required. Escalative steroid refractory, so we need to evaluate 48 to 72 hours. Or if they are steroid dependent, we need to add organ-specific second-line immune suppression. The multidisciplinary management improves outcome. An oncologist should lead this management. We need to consult other subspecialties if they need it, especially for higher grade 3 and 4. And by this, thank you.
I would like to thank all the speakers for their elegant presentation, and we'll now open the floor for the questions. We'll start with you, Prof. Ahmed. Yeah.
Thank you for the speakers. Really, it was very comprehensive talks. We'll start with Dr. Assam. You nicely presented the DATO and SASI data, and you mentioned that there is crossover in the SASI trial, while what was not there. And we ended up that there is overall survival for the DATO, while lacking survival in the SASI. And also the use of the administration way of SASI twice per cycle, once per for that. My question is about what is your take from these data? Which one you think would this overall survival for choosing between the two? Thank you.
Okay. Hello. Hello. Okay. Thank you for the multi-phase question. All right. When we base our decision of what treatment to choose, of course, so many elements should be taken into consideration. The first element is the progression-free survival. Okay. Second to that, I will not put the overall survival as second. I will put the toxicity profile and the patient profile. Okay. Third, the availability. Okay, and the easy access or the accessibility. Fourth is the overall survival, right? And we know that overall survival in metastatic breast cancer does not have that larger impact as an adjuvant, because when you look at it, you look at progression-free survival, you look at progression-free survival 2, okay? And you look at the rate of toxicity and the cost effectiveness or the health economics. So my choice, because we have a wide experience with sacituzumab govitecan, okay, and not for the company to be happy with this, but yes, I will go for SASI basically for one reason: availability and registration in Saudi Arabia. Okay. The overall survival is not mature. When you look at the 12-month analysis, it was equal. Okay, definitely the crossover has affected that, and this is actually an advantage rather than a disadvantage, because you cannot deny these patients the access to treatment, and this was reflected on the progression-free survival too, okay, which very much improved. So simple answer, for the time being, I'll go with SASI, okay, and bearing in mind the other serious toxicities that have occurred with DATO, I'm a little bit reluctant to do so.
For Dr. Abdullah Tawerghi, about the rapidly progressor, you mentioned nicely that still, despite of the PD-L1 positivity, I have 2 patients, PD-L1 100%. Despite of that, they progressed rapidly, and the opposite. So what is the explanation for such progression? And this really put in question about
progression on the first line or relapse from the neoadjuvant?
In the first line.
Yeah, so I think that's have to do with the biology of the triple negative. It's quite aggressive biology. I do believe that we have to use the important tools in the first line before we make the decisions. And the 2 important tools are the PD-L1 and the BRCA. And that could help to make the decisions when it comes to chemoimmunotherapy or ADC immunotherapy, whatever the choice. But I don't think the response is 100%, and this has been seen even with the latest data from SG Pembro, where the response is 60, the BFS is around 7 months. So whatever response is might be durable, but it's not the way we deal with other disease. So I agree that's not all of them they will respond, but the only choice where I have to use chemo IO or ADC IO, it have to be PD-L1 positive tumor. And this is even if we have a BRCA positive disease. And this is, if you look at the guidelines, still they support chemo IO for patient with PD-L1 positive tumor if they are expressing PD-L1 more than 10 CPS score, including the BRCA positive disease. And that was the main indication. But that would be my preference case. Definitely the ADC has been one of the options with immunotherapy in the guidelines. I do understand putting this as an option because I think when it comes to triple negative, as you mentioned, they are progressing rapidly. So it's one of the unmet need. Even if there is a modest benefit, it's pushing this as a first line therapy. I do believe that once we have a clear survival, maybe we'll have definitive evidence in the first line.
If I
Yeah.
one more question for Dr. Sharif. Nicely, you presented the genomics and genetics of triple negative. Now, the point that usually we are hesitant to use PARP inhibitors in the second line. We believe that they are not working well, especially with the high burden disease. And I think also when we see Olympiad trial, the previous use of platinum was exclusion, and also the benefit after, carboplatin was not that good. Maybe you showed that Talazo showed better results. So do you think that still there is role for PARP inhibitors in the second line of triple negative breast cancer, especially because our patient, most of them, they are coming after 335 protocol, so they use platinum. And you showed us very narrow care, almost overlapping curves for those patients who received platinum in the first line. So using PARP inhibitors after the platinum still working, and if you decide to use it, you will use the Talazo or olaparib.
Okay, thank you, Dr. Ahmed. I will start with the last sentence. Should I use talazoparib or olaparib? If I don't have talazoparib, I have only olaparib, so whenever I will choose the available drug. But I believe that both, they have of the same family. It is a family action when it comes to platinum sensitivity or not. We learned this from other cancer model, like ovarian cancer, for example. More the interval is long, better the sensitivity and the response to PARP inhibitor it is. I would use it after platinum, yes, especially for patient, or mainly for patient who do have a long interval, more than 12 months. And if I have a short interval, I will not put it. I will maybe put in sandwich another line of treatment. Then I will put the PARP inhibitor in order to make the window larger. We need to know that after 2 lines of treatment, because you mentioned 3 to 5 lines of treatment, we are talking about very poor outcome patient. Since second line, we are talking about 8 to 13 months roughly, maximum overall survival after the first line treatment if you have a recurrent disease. What the best chemotherapy in this setting is adding 2 to 3 months median difference in terms of progression-free survival. And this is what we have seen from the PARP inhibitor trials, both talazoparib and olaparib. The magnitude of benefit is only 2 to 3 months. It is positive statistically, but it is not as we were hoping or expecting before seeing the results. Yeah.
Question.
Thank you all the speakers for their nice presentation. My question may be fit for Dr. Essam Murshid, who presented data of using SG with immunotherapy, and for Amina Tijani, who presents the management of immunotherapy. If you have a patient using SG on immunotherapy and she developed ILD, especially if this patient has lung metastasis, how you will handle the case? Will you stop? Which one will be stopped? And how do you manage the case?
Thank you. First of all, the incidence of ILD with SASI is almost very, very rare, and it was not reported at all. But anyhow, the management of how we approach ILDs, of course, the first thing is to prevent it or to catch it up early. And what we do and what is recommended now is that we should do high-resolution CT scans every 6 weeks. And you don't wait for symptoms to develop. Or if you have any symptoms and you are doing it every 6 weeks and you have symptoms, cough, etc., respiratory symptoms, you have to interfere immediately and do it. According to the grade, whether you stop, you reduce, but The development of ILD is almost an indication to stop treatment until it is resolved 100%. It depends on the grade, whether grade 1, grade 2, or grade 3. Of course, grade 3, grade 4, you have to stop definitely, and you have to treat aggressively. The key element in managing those patients is the availability of a pulmonologist who is well experienced in this field. And I was just telling the guys, we were blessed at PSSMC, where we have two pulmonologists with a fellowship in pulmonology oncology, taking care of side effects as well as cardiology and GI. So our life is very easy with these guys, actually.
Last question before we conclude for Dr. Amin. You present, Dr. Amin, the toxicity of immunotherapy and the incidence is mainly in the 6 months. Now we have a patient with long-term on immune therapy. What's your recommendation to what's to monitor for patient for a long time on immune therapy, more than a year to 2 years?
Okay, thank you, Dr. Wissam, for this question. Actually, for the monitoring, the main monitoring should be in the first 3 months. Each cycle we need to monitor for that. After that will be like regular, depending on if there is symptoms or abnormal labs. So, but most of the patients, if they did not develop these side effects earlier, so most likely they will continue without toxicity, although anything expected. But it depends, it will be guided by the symptoms or lab or scan or something like that.
Okay, I think we reached the time, and I would like to thank the speakers for their presentation, and also to us, the audience, for their questions and the discussion. I would like to thank the Dr. Adel, who is moderating the session with me, and the organizer, Dr. Mohammed and Dr. Nafisa, for organizing scientific this program. By this, we'll conclude. I think we'll have, for how long? For 1 hour lunch break. Yeah, we'll see you. And the next break, next session will be about the HER2 management, the treatment. Thank you.
Good afternoon, and really thank to Dr. Nafis cancer with the aim of potentially de-escalating treatment. Please find here my disclosures. And let me start by reviewing the EBCT
Assalamu alaikum wa rahmatullahi wa barakatuh. We will start the second session for the day 2, and we'll have Professor Valentina Guérini. She is oncologist, Department of Surgery and Oncology and Gastroenterology, University of Padova in Italy. And she will give us 2 lectures back to back. The first one is about de-escalation strategies, biomarker, code-defined treatment algorithm for early stage HER2 breast cancer. And the second talk about emerging treatment in HER2 positive advanced breast cancer. Welcome Professor Valentina.
Good afternoon, and really thank to Dr. Nafisa for the kind invitation to join you, at least virtually, in this very important meeting. My role today in my first presentation is to discuss how biomarkers can be helpful in refining treatment algorithm for the treatment of early stage HER2 positive breast cancer with the aim of potentially de-escalating treatment. Please find here my disclosures. And let me start by reviewing the EBCTCG meta-analysis, including more than 30,000 patients enrolled in the 7 randomized pivotal trials evaluating the role of 1-year trastuzumab plus chemotherapy versus chemotherapy alone in as adjuvant treatment of HER2 positive early breast cancer. And here you can see the impressive results in terms of the reduction in the risk of recurrence, but also in the reduction of breast cancer mortality by adding trastuzumab to standard chemotherapy. And this, we can say that has represented for years our standard therapy for all patients presenting with HER2 positive disease. Anyway, in the past 20 years, we can say we faced really the emergence of new anti-HER2 agents, including pertuzumab, daratumab, T-DM1 in the post-neoadjuvant strategy. So, and also the improvement in the knowledge of the biology of the HER2 positive disease really question the approach of treating all the patients as being has a high risk, and also with the possibility of increasing the HER2 efficiency of the HER2 targeting. Also, we start thinking about the possibility of reducing at least the exposure to chemotherapy. And a lot of trials have been conducted with this perspective, but we have to say that now we are really using de-escalation in the context of HER2 positive early breast cancer only in 2 situations. The first one is for patients with low stage, patient with stage 1, on the basis of the results of the APT trial. This is a single arm phase 2 study evaluating a reduction of the exposure to chemotherapy, so 12 weeks of paclitaxel, of weekly paclitaxel plus trastuzumab, followed by trastuzumab for completing the 1 year of anti-HER2 treatment. We have seen a lot of update of this very important trial. This is the analysis at 10 years, really showing the excellent outcome of these patients treated with de-escalation chemotherapy. And this is now approved and endorsed by all the guidelines for patients presenting with stage 1 disease. Of course, we have to consider when I translate this trial in our routine practice that in this trial we have more than 40% of patients with grade 1, grade 2 disease, 67% HR positive, almost half of the patient with tumor 1 centimeter of less. So really low, very low stage patient population. The other scenario is in the context of neoadjuvant treatment. You know that neoadjuvant approach has been used with the aim really to personalize treatment, in particular with the possibility of modulating the post-neoadjuvant therapy according to the response, and in particular the response to therapy, namely pathologic complete response or non-pathologic response, residual disease, as a very important correlation with long-term outcomes. So it's really one of the most powerful predictor of patient outcome, and a lot of strategies have been really evaluated on the basis of offering treatment according to the response. And in this perspective, here we have the second clinical situation where we are all ready for de-escalate treatment in terms of omitting anthracyclines. We have a lot of neoadjuvant trials, namely Trifina, Train2, and most recent NeoCARP, the CompassHER, that demonstrated that without anthracycline we can reach the same at least level of pathologic complete response. For some of this data, this trial, we also have preliminary data on the outcome. So for patients treated with the neoadjuvant therapy, we know that we can omit safely anthracycline without compromising the possibility of a pathologic complete response, which remains the most powerful predictor of the long-term outcome. Anyway, what is important to consider is that when discussing about personalized therapy, escalation is straightforward. We know that higher pathologic complete response rate means improved survival. For those patients without PCR, we can escalate in the post-neoadjuvant setting, and now we have seen the results of deruxtecan as compared to T-DM1 as post-neoadjuvant therapy. So very clear way to move versus personalized therapy in terms of escalation. De-escalation is more challenging, and we cannot consider in our practice to de-escalate treatment unless we have a clear demonstration, a prospective demonstration that we are not losing anything in terms of a long-term outcome. And in this perspective, we have to work through biomarkers and early predictors of response. And for the purpose of this presentation, I will discuss some data on regarding the prognostic role of tumor-infiltrating lymphocytes, the role of functional imaging, the potential role of ctDNA, and also we'll discuss on the possibility of stratifying prognosis, but also to work on the prediction of pathologic complete response with the genomic tool HER2Dx. Let's start with the TILs. TILs, tumor-infiltrating lymphocytes. We discuss a lot of in terms of the prognostic role of TILs in triple-negative breast cancer, but we have very important data also in the HER2-positive disease. These are data of evaluation of TILs in the EPTCG meta-analysis of the adjuvant trastuzumab trials. TILs are prognostic. And here you can see the outcome according to the level of tumor-infiltrating lymphocytes. Anyway, do not predict for the adjuvant trastuzumab benefit. So prognostic, but not predictive for trastuzumab benefit. Let me briefly discuss this. This is our one old study that we conducted in 90 hospital in Italy. This was one of the first de-escalation trials in the context of a HER2-positive disease. So we randomized patient to standard anthracycline taxane sequence plus 1 year of trastuzumab versus a short trastuzumab administration with also shorter chemotherapy administration on the basis of the preliminary results of the FINHER trial. We randomized more than 1,200 patients. This is the main publication and the updated with the 10 years update regarding the disease-free survival and the overall survival. The trial was designed as non-inferiority trial. Formally, we were not able to demonstrate the non-inferiority of 9 weeks plus chemotherapy, 9 weeks trastuzumab plus chemotherapy versus standard long 1 year trastuzumab exposure, but you can see here the curves in terms of disease-free survival and overall survival that are almost superimposed. Anyway, we also use this platform for a lot of biological analysis, including tumor infiltrating lymphocytes. And here is one very recent publication. This is the first demonstration that tumor infiltrating lymphocytes impact on overall survival in the context of HER2-positive early breast cancer. And here you can see the distant disease-free survival according to the treatment arm, short versus long, in patients with low and high TILs. And you can see that patients with high tumor infiltrating lymphocytes really have an excellent outcome with just 9 weeks of trastuzumab. Of course, this will not change our practice, but can be a stratification factor, in particular considering that all over the world there is not uniform access to drugs. And at the last San Antonio meeting, we also have presented an analysis integrating the manual evaluation of TILs, because there is also a lot of discussion on the standardization of the TIL scoring system. So by using also an AI integrated tool, and I will reported here the results of this manual plus AI evaluation presented by Roberto Salgado in the Affinity trial, the trial evaluating trastuzumab and pertuzumab in the adjuvant setting, and in the shorter trial, where in the end the performance is similar of manual and integrated with the AI. We have a slightly higher performance of the integrated tool with the AI in those patients in the intermediate TILs category, and overall is confirmed the prognostic stratification, the prognostic role of TILs in the context of early breast cancer treated with trastuzumab and also treated with the trastuzumab and pertuzumab. Also, TILs can be useful in refining the prognostic role of residual cancer burden. You know that residual cancer burden is the way to further stratify the risk in patients without pathologic complete response, again to evaluate those patients that can be candidate to escalate or to de-escalated therapy, where patients with residual cancer burden 1 has a very similar prognosis as compared to those patients with residual cancer burden 0, so pathologic complete response. And this is again an analysis from my group showing that the integrating of TILs to residual cancer burden can further refine the prognostic stratification in patients treated with neoadjuvant chemotherapy plus anti-HER2 therapy. So moving to the concept of using functional imaging, I just want to use this editorial that I write together with Professor Deci from my group, commenting on the FERGAIN trial that I will show you now. Really emphasizing the importance of the risk stratification, but also the importance to really work on prospective trial aimed at treatment de-escalation. And the FERGAIN trial is a very important trial, very interesting trial. Seems complicated, but I will simplify. This strategy of this trial is using a PET scan to identify early responders. So in patients with early response to only the monoclonal antibodies trastuzumab and pertuzumab, those with the response continue without chemotherapy. And again, after surgery, treatment is allocated on the basis of the response. And patient with in group B, so treated with the response after PET scan, that continue on endocrine therapy in case of hormone receptor positive disease, but with the two monoclonals, and then surgery, and then in PCR continue without chemotherapy. Here you can see the outcome at 3 years. Of course, the follow-up need to be prolonged, but you can see really very good outcome totally without chemotherapy, only on the basis of the selection of early response after 2 cycles of treatment without chemotherapy. And at San Antonio this year, Antonio Lombard presented also this very interesting data evaluating the role of ctDNA in this patient population. So this is the FERGUIDE, so a subgroup analysis, a sub-study of the FERGAIN study. And I've summarized the main messages for the sake of time. In particular, the presence of baseline ctDNA, which is something that interested more than 70% of the patient population, correlated with the clinical stage, but did not predict for pathologic complete response. The clearance of ctDNA at pre-surgery occurred in 83% of the patients, and the early clearance at cycle 3 was strongly correlated with pathologic complete response. And another very important information, so at cycle 3, with this evaluation, we can predict the patients we can early predict the patients that will have a pathologic complete response. And the other very important information is on the prognosis. So what they demonstrated is if you have low ctDNA or not detectable ctDNA or clearance during the adjuvant therapy, patients have a better IDFS at 3 years. And these are the curves clearly showing the difference in prognosis according to the dynamics, to the pre-surgery status, and on the dynamic of ctDNA. And lastly, I will discuss with you the potential role of HER2-DX in the context of personalization, escalation or de-escalation treatment in HER2-positive disease. I worked together with Aleš Brat. This genomic tool has been developed also by using the data from the shorter trial. So really a tight collaboration with the group of Barcelona. This is a tool which is very important because it combines the traditional clinical data, including stage, nodal stage, with the information that derives from 4 signatures, 4 gene signatures that capture the immune infiltration, the luminal differentiation, the proliferation, and the expression of the HER2 amplicon. And there are a lot of validated retrospective cohort, and I will show you some data. And what is important, what is new with this tool is the fact that it is able to predict the score, the risk with the HER2-DX risk score, so can identify patients with good prognosis and with poor prognosis, but also is developed to be able to predict the likelihood of pathologic complete response. So you have the 2 information. likelihood of pathologic complete response and the risk. And this is very important because traditionally the factors associated with the higher rate of pathologic complete response are generally those associated with the higher disease aggressiveness, such as grade 3, high proliferation, and so on. So here you can capture both the information on prognosis and probability of pathologic complete response. And this is a large meta-analysis evaluating the association of HER2-DX with pathologic complete response, and here you can see the performance of the score, the HER2-DX in predicting the pathologic complete response in these trials, and this is independent of the expression of hormone receptor, and also the information on prognosis. And what is very important is that it adds on the classical prognostic role of pathologic complete response, because you can see that you can discriminate the patient at different prognosis according by using the risk score, even in the group of patients with pathologic complete response, as summarized here. So this is important because can be helpful in really identify those patients with pathologic complete response where we can de-escalate in a safe way additional therapies. And I just want to mention the CompassHER2. This is a trial where patients received treatment, 4 cycles of THP, and then treatment according to the response with further randomization. And we have seen the according again to the response. And we have seen at ASCO the results in terms of pathologic complete response rate, and you can see that THP times 4 is associated with a really important level of pathologic complete response. We have, in particular, in the hormone receptor negative cohort, 63.7%. And here are the factors significantly associated with pathologic complete response in multivariate analysis, which are the lower ER expression, having immunohistochemistry HER2 3+ versus 2+ and ISH amplified, and the paclitaxel use versus docetaxel. And we have seen the results of the HER2-DX pathologic complete response score in a subgroup of patients enrolled in the CompassHER2, so a prospective integration of this tool. In the evaluation of the performance in predicting the pathologic complete response after 4 cycles only of THP, and in the multivariable analysis, you can see here the 3 factors previously identified, and here the HER2-DX score maintain a prognostic role, possibly with a significant association, adding to these parameters the ability to further predict the pathologic complete response. And also we will see in the future also the data on the outcome. And this is just to conclude, because I've alluded the fact that we need to generate data from a prospective randomized trial, and this is a study which is ongoing. It is conducted in a big European consortium, and this trial is aimed to confirm the role of HER2-DX in guiding treatment physician choice, with the objective of personalized therapy in terms of de-escalation and escalation for those patients with suboptimal response to standard therapy. And thank you all for your attention.
We'll proceed with the second talk, which will be about the which is emerging treatment in HER2-positive advanced breast cancer by Professor Valentina. Please, Professor Valentina, if you can go ahead with the second talk. Professor Valentina. Oh, she is not.
Really And now my role is to discuss the evolving scenario in the context of HER2-positive advanced breast cancer. Again, my disclosure. So in the past years, we really faced the emergence of new anti-HER2 agents, new anti-HER2 strategies that really translate in survival prolongation. And the availability of multiple lines of therapy really changed the prognosis of patients diagnosed with metastatic HER2-positive breast cancer. And this is, to me, is very important analysis deriving from real-world data, where you really can measure the overall survival benefit over time. And this improvement really parallel the availability of newer and newer agents available for routine clinical practice. For more than 12 years, Cleopatra has been the standard first-line therapy for patients with HER2-positive metastatic breast cancer. Really impressive results in terms not only of PFS benefit, but even more pronounced overall survival benefit. And these are the curves of the end-of-study analysis published 5 years ago by Sandy Swain, where to me is really impressive the analysis at the landmark analysis at 8 years, where you see that in patients receiving pertuzumab, trastuzumab, and chemotherapy, we have 37% of the patients alive. So at 8 years, this is really an impressive result. And and this is what is now endorsed by ESMO guidelines, where you can see that the trastuzumab, pertuzumab, and taxane represent the standard first-line therapy for patients with metastatic HER2-positive disease. This is a very recent update with the possibility, of course, out of EMA or FDA approval of the addition of a maintenance treatment with the palbociclib. And this is on the basis of the results of the PATINA trial presented last year at San Antonio. The PATINA trial evaluated the role of adding palbociclib to endocrine therapy after induction chemotherapy with a Cleopatra-like regimen, so 6 to 8 cycles of chemo trastuzumab plus or minus pertuzumab, but the vast majority of the patients enrolled in the trial received dual blockade, so the pertuzumab use is 96% of the patients, and in patients with the completion of induction chemo and no evidence of disease progression, so complete response, partial response, or stable disease, randomized to palbo plus trastuzumab, pertuzumab, and endocrine therapy. It is important to remind that 73% of the patients have received prior anti-HER2 therapy as adjuvant or neoadjuvant therapy, and the vast majority of the patients received aromatase inhibitors as endocrine therapy. And here I have to say, impressive results in terms of PFS. You can see that the addition of palbociclib plus anti-HER2 therapy and endocrine therapy translate into 44.3 median PFS versus 29 months with the standard anti-HER2 plus endocrine therapy in the control arm. So really very important data with the toxicity profile consistent with the very well-known toxicity profile of palbociclib. So really, in my view, very important data in terms of maintenance strategy for patients with triple positive disease. And at last San Antonio, we have seen another trial, the HER2CLIMB-5, evaluating the potential for maintenance therapy after an induction with the Cleopatra-like treatment approach. Here we have patients with HER2-positive metastatic breast cancer. It is important to highlight the fact that we have approximately 70% of patient population presented with de novo stage 4 disease, half of the patient with hormone receptor positive disease, presence of brain metastasis, asymptomatic brain metastasis in 12% of the patients. Here, after 4 to 8 cycles, the median number of chemo cycles was 6 in both arms. So after induction therapy, in case of no evidence of progression, randomization to continue trastuzumab, pertuzumab, plus or minus endocrine therapy, and tucatinib or placebo treatment until toxicity or disease progression. The study, as presented by Erika Hamilton at the last San Antonio, was positive in terms of the primary endpoint of the primary endpoint, so significant improvement in progression-free survival. So we have a median PFS that is increased from 16.3 months to 24.9 months, statistically significant. And of course, the trial is positive, but in the context of the evolving scenario, really don't know if there will be a role for this strategy. And here I reported the results according to the expression of hormone receptor. You can see the HR negative 24.9 months, 25 in HR positive. I have to say that also taking into account the patina data, here we have for the triple positive patients a suboptimal use of endocrine therapy, because here only less than half of the patients have received also endocrine therapy together with the maintenance. So probably the addition of endocrine therapy would have a little bit improved the median PFS of the triple positive patients. A lot of discussion, you know, that tucatinib has a particular demonstrated particular efficacy in patients with active brain mets or with brain mets in general. Here are the data of the CNS PFS, so no difference in the ITT population, but very limited number of events. And in the 12% of the patients presented with brain mets at baseline, as suggestion, if you look at the median PFS, 8.5 versus 4.3, but overall caveat in discussing this data, because again, the very limited number of events, we are comparing 24 events versus 28. So of course, the trial overall is positive, but I don't see a clear positioning or potential positioning for this strategy. Because, of course, in this context, we have the game changer trastuzumab deruxtecan, new generation ADC, with also the potential for the bystander killing that led to the approval also in the HER2-low patient population. In the HER2-positive subset of breast cancer patients, really impressive results. These are the data from the DB03 comparing TDXT versus the standard second-line therapy TDM1 at that time. So in patients with previous treatment for metastatic disease, primary endpoint progression-free survival. Here I've reported the results also of the responses, because if you look at the plot, really impressive results in terms of the activity of deruxtecan. And here we have the PFS data, the OS data, really impressive data in terms of the performance of TDXT. In terms of PFS, we have a median PFS of 28 months versus 6.8, and a significant advantage in terms of overall survival. And I have also reported here the updated OS. We have a median OS that of exceeding 52 months. So very, very important data that really clearly indicate the trastuzumab deruxtecan as standard second-line therapy for patients with HER2-positive metastatic breast cancer. Also, according to the guidelines, there is a discussion of tucatinib in patients with active brain mets on the basis of the HER2CLIMB data, but overall we also face a growing body of evidence of the activity of TDXT also in patients with active brain mets on the basis of the DB12 study. And so what is the most recent data in the context of HER2-positive metastatic disease are the results of the DB09. The DB09 is a 3-arm study, first-line therapy, evaluating the potential role of TDXT in first-line therapy. 3 arms, TDXT placebo, TDXT pertuzumab, and the standard Cleopatra arm THP. We for the moment have only the results of the comparison between TDXT pertuzumab plus THP, because the TDXT alone arm is blinded until the final PFS analysis. So for the moment, not enough events. Patients stratified according to the de novo versus recurrent. Again, important number of patients with de novo metastatic disease, more than 50%. HR positive 54%, 30% of patients also with PIK3CA mutation. Primary endpoint progression-free survival, and again we see here the results significant from the statistic, but in particular from the clinical standpoint, more than 40 months of median PFS versus 26.9 months with the standard THP. So really a median of approximately 40 months of gain in progression-free survival. And here the subgroup analysis, the results are very consistent in all the pre-specified subgroups. And again, also important results in terms of response. In particular, we have doubling in the complete response, and we know that the patient will be this excellent outcome after 10 years are those with the complete response. So probably we are increasing the number of patients where in the end we will at some point can discuss about the possibility of really eradicating the disease in the metastatic setting. This is the update presented by Sibilla Tesmo, by Sibilla Oibla Tesmo. The outcomes in terms, according to the de novo versus recurrent disease, hormone receptor positive or negative, PI3K detection or not. As mentioned, consistent results in terms of hazard ratio, but if we look at the median in particular, I found impressive the performance in patients with PIK3CA mutation that have a worse prognosis. And in terms of hormone receptor positive cohort, again, in my view, I have to say suboptimal use of the maintenance endocrine therapy, because only 13% in the T-DXd plus placebo plus pertuzumab arm have received endocrine therapy, and 38% in the THP. And also ESMO guidelines endorse the maintenance as soon as you stop chemotherapy to continue with also the hormonal therapy as in the and the importance of co-targeting the hormone receptor pathway has been more recently highlighted by the PATINA trial. PFS2 by subgroup, again, the benefit in first line is translated into second line. Of course, we will have to wait for the maturation also of the OS data, but really very important data. So these are now the algorithm where we have Cleopatra, then the Ruxecan, then tucatinib, and then other HER2 targeting strategies. The algorithm is probably likely to change very soon. Of course, what can be the scenario? Of course, with the median PFS that exceed 3 years, now is difficult not to consider T-DXd pertuzumab as emerging new standard in first line, even on considering the second line benefit that we have observed when using T-DXd in second line as per DESTINY-Breast03 trial. In my view, an induction Cleopatra followed by PATINA-like approach still can be considered very important in patients presenting with triple positive disease. Of course, where is a question mark is if we can apply a maintenance strategy according to the PATINA or to the HER2CLIMB-05 after T-DXd plus pertuzumab induction. However, it is important to consider that the median T-DXd plus pertuzumab treatment duration in the DB09 is exceeding 21 months. So I'm not sure that 6-8 cycles of T-DXd followed by maintenance will translate in the same PFS benefit observed in the DB09 study. Of course, the scenario is evolving, also taking into consideration that the evolving in the early setting is going to change. We have seen the positive results of DB11 introducing a T-DXd in the neoadjuvant setting, but also of the DB05 introducing the T-DXd as post-neoadjuvant strategy. So in the near future, probably we'll start to see also patients that have been exposed to the DXd in the early disease setting. And of course, the algorithm has to change accordingly. Ongoing trials, the Demeter phase 2 study is evaluating the concept of induction followed by maintenance. This is, of course, a single-arm study. Here we have the ctDNA monitoring to evaluate and to modulate the treatment. But in the end, we will wait for these results. But again, the lack of control arm, I don't know if we will translate this in our practice. And in terms of different maintenance with newer hormonal therapy, just want to mention the Heredera, which is evaluating the role of SERD together with the trastuzumab pertuzumab as maintenance therapy, so with giredestrant, and other trials such as the INAVO 122 is evaluating the co-targeting of PI3K with inavolisib in patients presenting with also HER2 positive disease and PIK3CA mutation. And lastly, of course, other strategies evaluating new targets, new agents. So we will stay tuned on modifying our algorithm according to the evidence from clinical trials. And thank you all for your attention.
Thank you. Thank you very much, Prof. Valentina. Very nice and excellent talks. Now it's my pleasure to introduce dear friend and colleague, Dr. Ala Haidar. Dr. Ala is a senior medical oncologist at National Guard Hospital. Dr. Ala will talk about the management of ADC toxicities.
So thank you so much, Dr. Nafisa and Dr. Mohammed, for this opportunity to be here and talk to you about this very interesting topic, the management of antibody drug conjugate toxicities in breast cancer. So first of all, let's try to make things easy and simple. What is an ADC? What is an antibody drug conjugate? We listened earlier today for the presentation of Dr. Essam about the ADCs and their survival benefit in the multiple submolecular subtypes in breast cancer. But what is an ADC? It is an antibody, a payload of cytotoxic agent, and a linker who binds those two things together. And why we are doing that? That because we need this payload of cytotoxic chemotherapy to enter the cell and minimize the systemic effect and maximize the intracellular effect. The side effect of ADC can generate in any part of this complex, and that means we can classify either by antibody or payload or as on-target or off-target toxicity. The on-target toxicity means that the healthy cells that express the receptor will bind to the complex and will start side effect, like when we have the HER2 receptor and the cardiotoxicity of HER2 agents. The off-target toxicity are related mainly to the cytotoxic payload, and that's why it's very similar to the side effects we know from chemotherapy. Other side effect mechanisms can be related to the Fc, which is a part of the antibody at the tail of it, and it can bind to mainly the immunocell like macrophages and start an immune activation. We have also the linker that can be either cleavable or non-cleavable that could produce instability, and the payload could be immaturely released and cause side effects similar to chemotherapy side effects what are known to us. Also can be related to patient factors like the baseline organ function and the comorbidities. We need to know that mainly the side effects of ADCs are related to the payload cytotoxic. And the payload are different between the various ADCs, like in the TDM1, the first comer was the microtubule inhibitor, and for the TDXD, it's a top 1 inhibitor. For SG, it's a top 1 inhibitor. And it's similar to irinotecan, why we see the gastrointestinal side effects in this agent. This is a picture of the most common side effects related to ADCs. We can see the broad spectrum of side effects. Everyone will be related to one of them, and it will differ due to what payload is related to this agent. If we go in details with every one of them, we have the ASCENT trial examined sacituzumab govitecan as first-line therapy in patients who were not able to receive PD-L1. And the rates of grade 3 side effects and treatment emergent side effects were similar for both groups, leading to dose reduction or treatment discontinuation were lower in the SG-VS chemotherapy. The adverse events observed were consistent with the known safety profile of SG that we experienced from previous indications. And what about the combination with immunotherapy? The quality of life was one of the secondary endpoints in this study, and despite the longer duration of treatment in the arm of SG plus Pembro compared to chemo Pembro, the rates of grade 3 or more side effects were similar for both groups, leading to dose reduction or treatment discontinuation were lower with SG plus Pembro. The adverse events observed were consistent with the known profiles of the both drugs, and there were no new safety concerns observed. For the sacituzumab govitecan compared to the single-agent chemotherapy, around 5% of the patients in both arms discontinued for any adverse reaction. Neutropenia or febrile neutropenia did not lead to any permanent discontinuation, and no patient discontinued treatment because of the diarrhea. The most frequent reported adverse events were neutropenia and diarrhea for the SG. And how we manage the diarrhea? The early intervention, the educating of the patient is crucial. We need to provide the medication from the first prescription. We need to educate them how to take the medication, to start with 4 milligram with the first loose stool, then followed by 2 milligram to up to 16 milligram. We need to educate them about continuing with this drug, and then in case of failure of loperamide, we have other options, octreotide, and less commonly, we may need to move to fluoroquinolone or atropine. It's very important to grade the diarrhea in a right way to better manage. One phase 2 trial, the PREMED trial, looked at the prophylaxis of side effects, mainly neutropenia and diarrhea in sacituzumab govitecan. 50 patients received loperamide 4 milligram day 2, 3, 4, then 9, 10, and 11, and GCSF prophylaxis day 3, 4, and 10, 11. And those were given to the first 2 cycles. The rates of neutropenia at any grade dropped from 70% to 28%, and the grade 3, which was most common, dropped from 34% to 12%. For the diarrhea, dropped of any grade dropped from 60 to 34%, and the grade 3 from 10% to 4%. As adverse event leading to dose reduction, interruption, and permanent discontinuation also dropped for the dose reduction from 33% to 14%. For the treatment interruption dropped from 66% to 30%, and no discontinuation were reported among patients who received this prophylaxis. And what about the newcomer, the Dato-DXd, in treatment of triple-negative breast cancer in patients whom immunotherapy was not an option? Despite more than double median duration of this treatment, the Dato-DXd, the rates of grade 3 or more and serious treatment-related adverse events were similar for both arms, and discontinuation were lower with patients who received Dato-DXd. The most common side effects in the Dato-DXd arm were eye dryness, stomatitis, and nausea. And for the chemotherapy were neutropenia, anemia, and leukopenia. The specific side effects seen with Dato-DXd, the treatment-related oral mucositis and stomatitis led to dose interruption in 11%, and 3%, reduction 11%, and no discontinuation. Grade 2 or more events resolved to grade 1 or less in 90% of patients. The treatment-related ocular surface events in the Dato-DXd arm led to dose interruption in 6%, reduction in 4%, and discontinuation in 1%. That means those are a new side effect for us, but the impact of them in this treatment is not that high, as we can see here. The ILD also have been seen with Dato-DXd, but maybe a lower grade than what we have seen in T-DXd. The mucositis is one of the most concerning side effects seen with this drug. And what we need to do is to well educate our patients about the mouth hygiene, the daily use of a steroid-containing mouthwash, and the supportive care is the most important management in this case. Also, again, the right grading of our side effects is the right way to manage them. Another newcomer, the sacituzumab tiromotecan, which used to treat locally advanced or metastatic hormonal positive breast cancer. In this drug, the incidence of all grade and grade 3 or more side effects were similar between the two groups, predominantly the hematological toxicity. Incidence of dose reduction were similar between the two groups, and there were no adverse event leading to the discontinuation and no treatment-related deaths. The most common side effects for both sacituzumab TMT and the chemotherapy were the hematologic toxicity, as we've seen here before. Grade 3 or more diarrhea occurred in 1% of patients and in the SASI TMT group, and lower ocular surface toxicity also seen with this treatment in eye dryness in 11%, 4% with corneal disease, and all grade 1 to 2. The ILD occurred in 1.5%, 1% of patients, all grade 1 to 2 in the SASI TMT arm. For the T-DXd, we are a bit more familiar with the side effects as it's moving between the indications. For the DB09, the median total treatment duration was 21.7 months. For the T-DXd, 16 months for the THP. The main treatment duration for taxane was 5.5%. For docetaxel, 4.5 for paclitaxel. And the main side effects seen with the T-DXd was nausea, diarrhea, and we have seen more peripheral sensory neuropathy with the chemotherapy arm. The ILD was noted with T-DXd more common than the THP as expected, and the left ventricular dysfunction as we know from the HER2 treatments. The mechanism of the lung toxicity is the alveolar macrophage expressed the amount of FC receptor, as we mentioned before, and they were and this is classified as an off-target toxicity. The management of ILD, as we know from previous practice, it's important to educate the patient about these common side effects. The CT monitoring with high resolution CT is important. Some recommendations will recommend every 6 weeks, and others will say every 9 to 12 weeks. But the most important that we are educating our patients and we do this scan. The 5S rules for the treating of ILD: for screening with careful patient selection and regular clinical assessment to exclude the symptoms of ILD. Scanning with high resolution CT scan. A baseline scan is recommended with repeat scan to performed every 6 to 12 weeks. The synergy, minimizing the risk of ILD, involves the teamwork, the multidisciplinary work, educating the patients and all the care team, and multidisciplinary management. The suspending treatment. TDXD should always be interrupted if ILD is suspected, and the TDXD can be restarted in the case of asymptomatic ILD that has already fully resolved. Steroids is the main treatment in case of TDXD-induced ILD, remains the most important management, with a dose to be adapted to the toxicity grade. Management of left ventricular ejection fraction. We know from our previous practice that we need to do a left ventricular ejection fraction assessment at baseline, and to be repeated every 3 months. For the Destiny Breast 11, the overall safety profile was favorable versus the dose-dense ACTHP, with a reduced rate of grade 3 or more side effects, serious side effects, and treatment interruptions, and the left ventricular dysfunction. The ILD incidence was low and similar in both arms. And as we move to the earlier lines in the Destiny 05, in the TDXD arm, cause of death were totally 3 deaths, 2 ILD, pneumonitis, and respiratory tract infection. In the TDM1 arm, causes of death were 5. Leiomyosarcoma of the uterus, aneurysm, non-neutropenic sepsis, and ovarian cancer traumatic pneumothorax. The drug-related ILD occurred more common with the TDXD as expected, and the most important is the highlighted side effect is the radiation pneumonitis, as we are talking about adjuvant therapy. The timing of adjuvant radiotherapy showed no difference in adjuncted drug-related ILD, and similar distribution of any grade of drug-related ILD events were observed with sequential and concurrent radiotherapy in both treatment arms. And the safety of TDXD versus TDM1 is not different from what we know about those 2 drugs. The same scene for Destiny Breast 11. And for other side effects, which is not mentioned here, or for the general management of side effects, it's very important that we still put a right grade and manage according to that. The multidisciplinary approach is crucial. It's important to involve the oncology nurses in the surveillance and to consider prophylaxis when it's needed, to go early with GCSF also when it's needed, to involve the pulmonology when we are talking about ILD, and if possible, consider the digital symptom reporting tools which will create a better communication with our patients. What do we need from the drug developers? We need to optimize drug antibody ratios. We need to improve the linker stability. We need mechanism to FC silencing. and payload diversification to better be able to sequence treatments. We need rational combination regimens, and the goal is broader therapeutic window with reduced off-target toxicity. And the future direction, we still need biomarkers for the side effects, mainly with ILD. We need predictors of adverse events. We need real-world registries to understand our population. We need prospective trials with the management tools. And as ADCs move earlier in disease treatment to the adjuvant setting and neoadjuvant setting, we need to include potentially curative setting, long-term safety profiling. And to conclude, the quality of life, despite a higher incidence of all grade adverse events with those drugs, the ADCs have been shown to delay deterioration in global health status and physical functioning more effectively than standard therapy. The multidisciplinary approach is important. ADC toxicities are predictable and predominantly payload-driven. ILD with TDXD demands structured surveillance and immediate steroid initiation. Neutropenia and diarrhea are manageable with proactive algorithms, and the early intervention preserve dose intensity and survival benefit. Thank you.
Thank you very much, Dr. Ala, if you can join us. And we will start now the questions. And I have, maybe we'll just allow for one or two. And I have one question for Professor Valentina regarding the escalation and de-escalation for the treatment of HER2 positive breast cancer. What do you think about de-escalation of a new adjuvant from chemotherapy to T-DM1 in a triple positive breast cancer with stage 1? And for escalation, what do you think about giving adjuvant TDX instead of T-DM1 in case of residual disease after a new adjuvant treatment?
Thank you for the question. Of course, T-DM1 has been evaluated in combination also with pertuzumab in the CHRISTINE trial, and can be a rational approach to de-escalate in terms of reducing the chemotherapy. Anyway, this strategy, apart from the demonstration of a PAT-CR rate that exceeds 50%, has not been endorsed in the guidelines. And also, I think that it is important to careful evaluate this approach, because there are data suggesting a suboptimal performance of T-DM1 in case of presence of heterogeneity in the HER2 expression. There are data from Dana-Farber showing a reduction in the rate of PCR, or even in the CHRISTINE trial, a high probability for early progression in case of HER2 positive disease, but with heterogeneity. That is something that is not generally reported in the pathology report. And regarding the issue of escalating with TDXD rather than T-DM1, I think that the data from the DESTINY trial are very significant in terms we can improve by 10% the event-free survival as compared to T-DM1. So considering also that here we have a high-risk population enrolled in the trial, I think that for patients with less than pathologic complete response after standard chemo plus trastuzumab, pertuzumab, we have to move to trastuzumab deruxtecan on the basis of these results.
Thank you. I think Dr. Ahmed has a question.
Thank you very much. Really very nice, almost comprehensive talks. My question for Prof. Valentina regarding you mentioned the COMPASS trial that we have some signals that paclitaxel better than docetaxel, one signal. The other signal also we can drop the carboplatin and maintain the same benefit in the neoadjuvant. So, and always we are thinking about the chemotoxicity, TZPH versus TPH. And from practical point of view, did these, signals change your practice to adopt paclitaxel rather than docetaxel? The other thing, still using TCPH or TPH for your neoadjuvant patient?
I think that the data, I have to say that I always in the neoadjuvant setting use weekly paclitaxel because it's manageable and because we have a suggestion also from adjuvant trial that weekly paclitaxel is better than 3-weekly docetaxel in the early disease setting. So I think that weekly paclitaxel should be also on the basis of the results from the CompasSer-2 trial that we have to stay on a weekly paclitaxel. The other point, carbo, no carbo, we have the data presented at ASCO suggesting the same pathologic complete response rate. I think that also considering the fact that for less than PCR, we have now the possibility, we will have in the near future, the possibility of having a very effective way to improve the outcome with TDXD. I think we can rely on weekly taxane plus pertuzumab, trastuzumab in the neoadjuvant setting without carboplatin. I think the HER2 positive disease, I don't really see now the need to continue to include carboplatin. Also, we had data from the metastatic setting that you remember old trials comparing paclitaxel versus taxane alone with trastuzumab only, same results. So.
Yeah, thank you. I have another practical question. I have one patient. She is triple positive and metastatic. She started on Cleopatra. After 2 cycles of Cleopatra, she showed breast fungation. Progression, local progression. So just after 2 cycles of Cleopatra protocol. So my question, and I don't want to jump to doing, toilet mastectomy is horrible, will be with this fungation, and jumping to the second line like trastuzumab deruxtecan, I think, too early, and I don't want to lose the first line. So do you think that escalation of the Cleopatra by adding platinum makes sense in her case?
No, you have nothing to lose by adding a couple of courses of carbo and see what happens. But if you don't have response to taxane, trastuzumab, pertuzumab, I fear that you have to move to TDXD.
For Dr. Ala, just quick question, a practical question again. For HRCT, usually we don't do routinely because we are doing pan-CT with contrast. So do you think that doing pan-CT, and we are doing every 3 cycles, then follow-up CT scan for our metastatic patient in HER2. Do you think that doing CT scan in the conventional CT scan without HRCT an asymptomatic patient without respiratory symptoms is enough? And do you do a pulmonary function test as baseline, or usually you do it for symptomatic patient before initiation of trastuzumab deruxtecan?
Well, about the CT, we need to do what is available actually. So if we don't have a high resolution CT,
we have it, but the point that you feel that HRCT plus conventional CT.
Yeah, exactly. No, what we try to do, that we do actually even in our center we don't do high resolution CT because we don't have authority to order it. But we try to do, if it's possible, high resolution CT every other assessment, and the other will be with the pan-CT as you mentioned.
And the other question about interaction between radiotherapy and TDXD in HER2. That means patient went for radiotherapy. When you resume the TDXD in HER2 after that, for fear of CNS the necrosis and the side CNS toxicity. So the interval between the brain radiotherapy and the resumption of the Enhertu.
Actually, in the study, they saw no difference between the incidence of the ILD if it was given concurrently or sequential. That was for the breast radiation. So for the CNS radiation, I will actually resume directly after if no ILD symptoms, and we don't expect it to happen from brain radiation.
Thank you, Prof. Valentina, for the excellent talks. One question. Now we do have the HER-Climb 05 study. We have Destiny 09, and we have Patina trial. How do you see the sequence? What will be the next step in sequencing management of HER2-positive advanced breast cancer? How can we start? And what will be the next if T-DXd gonna be the standard of care very soon?
I think that this is really the key question, because of course we have seen the results of the DB09, but we know that the DB03 really provide very, very important data in terms of the benefit of on OS. I think that in a way with the T-DXd first line, we have more than 3 years of median PFS, and this is really something that is meaningful. So I think that for patient presenting with the high disease burden, or for patient with PIK3CA mutation, patient with in particular hormone receptor negative disease, I think that that the Ruxtecan will be plus pertuzumab will be the optimal strategy. For patients with triple positive disease, I think that we still can postpone the use of T-DXd by applying induction chemo and then the Patina approach, but I don't know, in Italy we cannot use for the moment Palbo in the maintenance phase. I actually have to say don't see particular role for tucatinib as maintenance strategy because you are these 25 months of median PFS do not, of course, we don't want to cross compare, but again, you lose a line because you can use tucatinib, capecitabine, and trastuzumab as a second line or third line, depend on what you are using in first line. So also given no signal for preventing brain progression, don't see a clear positioning of tucatinib in the maintenance phase. We will see whether we will have data showing the potential for have induction with T-DXd and then maintenance with the other strategies. But for the moment, I see Patina approach for triple positive disease and the Ruxtecan for patient with a high burden or highly aggressive disease.
Any more questions? Thank you, Prof. Thank you, Dr. Ala, and nice hearing from you all. And thank you, Dr. Munira, for
chairing this
session. And I think by this we can conclude and move to the next session. So the next session will be a satellite symposium by Minarini, and it will be chaired by Dr. Adil. And Dr. Adil, please.
Thank you, Dr. Nafisa, and welcome everyone to our satellite symposium by Minarini. I'll be happy to introduce our speaker, Dr. Miriam Lutzberg. Dr. Miriam Lutzberg, she's the Chief of Breast Oncology and Director of Breast Cancer at Yale Cancer Center, New Haven, US. and she will give us a talk on the novel oral SERDs and the second line hormonal positive HER2 negative. Dr. Miriam, with us?
Shukram, assalamu alaikum. Thank you everyone for being here today. So we'll be covering today the rich landscape of targeted therapies available for hormone receptor positive metastatic breast cancer. Here are the ESMO guidelines in terms of how we think about hormone receptor positive metastatic breast cancer. Typically pending availability in the first line setting. We start out with aromatase inhibitors and CDK4/6 inhibitors. And then it's after that first progression where it's critically important to understand the genomic pathway that is driving the tumor. And we'll be talking about the different targeted approaches available for patients, including those who acquire an ESR1 alteration, which this particular alteration, as you know, makes the estrogen receptor constitutively active and less responsive to some of our other more traditional endocrine therapy agents. The first agent for these ESR altered tumors that was approved was elacestrant. And here you see the schema for the EMERALD study, which was the phase 3 trial comparing elacestrant versus standard of care endocrine therapy. It's really important as we talk about all the upcoming studies that we think about the patient population that was included. As you can see in that red box, this was a fairly heavily pretreated population that had seen prior CDK4/6 inhibitor. They may have had prior fulvestrant and prior chemotherapy. Primary objectives were progression-free survival in the ESR1 mutant tumors, as well as PFS in all patients. As you can see, the patients, a good proportion of patients had visceral metastases, all had CDK4/6 inhibitors. 37% had prior fulvestrant, and 23% had prior chemotherapy. The results, as shown here, showed that there was a statistically significant improvement in progression-free survival in both the ESR mutant patient population as well as in the intent to treat patient population, with median progression-free survival of 3.8 months in the ESR1 mutant patient population with a hazard ratio of 0.55. The absolute difference between elacestrant and the standard of care group was 3.4 months, which is clinically meaningful. And delving in further into which patients actually derived the most benefit from elacestrant, taking the metric of which patients had been able to sustain clinical stability on prior CDK4/6 inhibitors of more than 12 months or larger. This makes sense clinically because by definition, this is a more endocrine sensitive population with a documented response to prior targeted therapy. So when we actually look at this population of patients who had had 12 months or greater response to prior CDK4/6 inhibitor, you can see that the median progression-free survival is 8.6 months. And then further subgroups that we'll talk about in a little bit are listed further. So this is the population most likely to benefit from the monotherapy with SERD, such as elacestrant. When we often have clinical trial data, we wonder how things actually perform in the real world when patients can have less robust clinical responses. However, 2 real-world data sets with elacestrant actually showed that the clinical benefit and progression-free survival were actually very comparable to the original EMERALD data. So one was looking at real-world data in the Guardant liquid biopsy database. Essentially in this particular real-world data, median time to next treatment change, which is a commonly used surrogate in real-world data, was 8.8 months in patients that received elacestrant. Again, very comparable to the EMERALD data. In a separate real-world data based on U.S. insurance claims, again, we're seeing median real-world progression-free survival of 8 months. So taken together, all of these are reassuring that even outside of a clinical trial, elacestrant is showing meaningful clinical activity. Putting it all together from kind of the EMERALD data as well as the 2 real-world data set that I showed you, you can see that the clinical characteristics are roughly comparable across the 3 different data sets. And again, we're seeing this consistent benefit of 8 to 9 months, very much in line with the EMERALD study subgroup analyses of patients that had that CDK4/6 inhibitor sensitivity of 12 months or longer. The safety of elacestrant has been consistently shown, both in the EMERALD study as well as in real-world data. Generally, very low grade 3 events in elacestrant, and discontinuation rates due to nausea, which is the most common toxicity, tend to be quite low. Antiemetic use is actually quite low. Generally, patients are able to tolerate these agents quite well and are able to maintain good quality of life while taking it. So then let's move on to newer oral SERDs and review the monotherapy data with these agents. So we have the VERITAC-2 study that was read out in last year's ASCO, which is a phase 3 trial of vepdegestrant, which is a PROTAC versus fulvestrant. Focusing again on the patient population, this is a less heavily pretreated population compared to the EMERALD study. They had this population had no prior fulvestrant and no prior chemotherapy, and they were randomized 1-to-1 to fulvestrant versus vepdegestrant. You can see the results here. And again, we see that there was improvement in progression-free survival to 5 months versus 2.1 months with fulvestrant, with an absolute difference of 2.9 months in the patients with ESR1 mutated tumors. There was not a significant difference seen in the intent to treat population. And I think this is partly reflecting that this population had, without the ESR1 alteration, had not previously seen fulvestrant. So the fulvestrant standard of care arm is performing better, reducing the difference, resulting in a more negative absolute difference. In terms of safety and tolerability, as we see with very much many of our monotherapies with SERD, grade 3 and 4 events are infrequent. Patients can have some nausea, some LFT abnormalities, and fatigue. And 10% of patients did have QT prolongation with vepdegestrant. Moving on to the EMBER-3 study, which is a phase 3 trial of another SERD, imlunestrant versus standard of care. This was a 3-arm study that included the monotherapy arm with imlunestrant, standard of care endocrine therapy, which could include fulvestrant or exemestane, or a combination of imlunestrant plus abemaciclib. Coming back to the patient population again, because it's really important as we compare these agents, this population was again less heavily pretreated compared to EMERALD, no prior fulvestrant, no prior chemotherapy. So kind of again, just kind of highlighting this patient population as we discussed previously. So what we see again, that we're seeing a positive signal in the tumors that harbor ESR1 alteration, with a median progression-free survival with imlunestrant being at 5.5 months versus 3.8 months in the standard of care arms, with a delta of 1.7 months. In the intent to treat population, we don't see a significant difference, but certainly the activity is there, but the standard of care arm is performing similarly. So the difference is not significant. So again, putting all this data together. So you're going to have eventually a menu of different SERDs to choose from as approvals are expected to come in. And it's just helpful. We certainly are not suggesting cross-trial comparisons, which are not statistically valid, but it's really important to kind of, in our mind, as we think about different options for our patients, to think about kind of the differences among these trials and the populations that were treated. For example, in the EMBER-3 trial, a third of the patients had not had prior CDK4/6 inhibitor treatment, whereas in the VERITAC-2 and the EMERALD study, they had prior CDK4/6 inhibitors. And you can see the median progression-free survival is listed. And from the actual SERD therapy standpoint, they are very much performing very similarly. Once we take out and focus on the patients who did not have prior chemotherapy in EMERALD, we can see that the magnitude of PFS is very, very similar when we account for some of the prior treatment differences. And so again, it's not meant to be, it's meant to be exploratory, but for us to really understand the data differences across these trials. In the next few slides, I will go over what happens when this situation comes up quite frequently in all of our clinics, is when a tumor has both an ESR1 acquired alteration as well as a PIK3CA co-mutation. And this happens quite a bit. And so I will move on to the next slide. We'll look at kind of how these co-mutated tumors behave. These data are from the EMERALD study, where the subgroup analysis looked at patients with coexisting ESR1 and PIK3CA mutations. And as you can see, there is continued meaningful activity in patients who had at least 12 months of stability on CDK4/6 inhibitors, and their median progression-free survival with co-mutations was at 5.5 months. A question that comes up is when we look at the fraction of the tumor DNA in the liquid biopsy that actually has the alteration. And sometimes clinicians are torn between, well, what if the PIK3CA VAF is higher than the ESR1? Do I need to then pick a PIK3CA directed therapy? And the answer is no. Even low levels of ESR1 detected in the liquid biopsy essentially still led to a meaningful progression-free survival. Why is this important? Why do we keep harping on what to do on these co-mutated tumors? The reason is that if there is an opportunity to use a SERD, it is much better tolerated for patients than any of our existing PI3K AKT pathway inhibitors. No matter which agent you're looking at, alpelisib, capivasertib, ipatasertib, they are, no matter what the agents, associated with high rates of hyperglycemia, diarrhea, rash, and stomatitis. And patients actually have high rates of discontinuation rates, even with maximal supportive care. So if there's an opportunity to use a better tolerated agent, I think our patients at least we owe it to our patients to have that discussion with them. So I think depending on where you are currently practicing, you will have different access to these agents, lots of activity in this selective estrogen receptor degrader or SERT space. And again, we have summarized the data for you more for reference, but we will continue to, as the presentation continues, delve into these different data. So I'm going to move forward for the interest of time and talk about kind of these actionable alterations and the importance of actually testing the genomics as you're making treatment decisions for your patients. Intrinsic mutations, also known as truncal mutations, these are present no matter when you're checking your tumor genomics, and these include things such as PI3K, AKT, and PTEN. In contrast, ESR1 alterations are acquired mutations, and we'll kind of talk about how we see these. They're acquired, they're subclonal, meaning their molecular profiles can vary across different tumor sites, and they can be quite heterogeneous. And if you check only in the first line and not in the second line, you're likely to miss it. So the timing of testing, in contrast to the truncal mutations, is quite critical. This schema continues to reinforce the point that longer exposure to endocrine therapy, particularly aromatase inhibitors, in metastatic breast cancer increases the chance of developing an ESR1 mutation during treatment. So we hardly see ESR1 mutations in the early stage breast cancer adjuvant treatment. When we're first starting therapy, 10% or less of patients actually have an ESR1 alteration. It's really as we move on to progression after AI and CDK4/6 inhibitors, where in the second line setting, you're going to see about 40% of tumors acquiring ESR1 alterations, and about half of tumors have it in third line and beyond. And so typically this higher ESR1 mutation, you're going to see it more at times of progression and is associated with more cancer aggressiveness and lack of response to some of the traditional endocrine therapy agents. The question that often comes up is, what is the optimal test for ESR1 testing? And liquid biopsy is preferred as long as it's available where you're practicing. It tends to have high sensitivity for ESR1 mutations. It's minimally invasive and has the ability to really look for the subclonal ESR1 mutations, and the yield is much better with these digital PCR assays. So generally, the guidelines prefer using a blood-based ctDNA assay as long as it's available where you're practicing. The SERENA-6 trial has been in the news with the question of, do we actually wait for patients to progress radiographically before we change to an agent that's effective for ESR1 alteration? Or what if we change their therapy sooner at the earliest detection of ESR1 alteration? So this was a high-profile study that was presented in last year's ASCO, and it has generated quite a bit of discussion about how we designed clinical trials in this metastatic breast cancer setting. So these were patients who had had at least 6 months of stability of disease while receiving an initial endocrine-based treatment with an AI and a CDK4/6 inhibitor. More than 3,000 patients were screened to come up with the 315 patient population that had ESR1 mutations detected in their ctDNA, and then then this population was randomized to continuing their current treatment, which is the standard of care, versus switching to another selective estrogen degrader known as camizestrant. And the primary objective was investigator-associated PFS. So the majority of the patients, their CDK4/6 inhibitor was palbociclib, and kind of again highlighting that the screening portion of this trial was quite intensive. Half of the population had an ESR1 detected at the first screening, but others needed more time for them to acquire. Again, kind of building on that, you need higher time exposure to aromatase inhibitor to acquire these alterations. So by the primary endpoint, the progression-free survival in the group that actually switched based on molecular progression with camizestrant was 16 months, compared to the group that continued on their existing therapy. Their PFS was 9.2 months. And in terms of patients, what happened to them after switching to camizestrant, the patients that had switched early to camizestrant, their next subsequent therapy tended to be chemotherapy, with 45.6% of patients receiving it, whereas the patients who had continued on standard therapy, 22% received chemotherapy, while the rest received some type of endocrine therapy and targeted therapy combinations, and a minority ADCs. So yes, by primary endpoint, this was significant, but what does it actually mean? Does this strategy truly improve overall survival and demonstrate clinical utility? The group that continued on their existing therapy had another 9 months response time, which is, I think, clinically meaningful. And there's been a lot of discussions about the design of this trial, and whether truly the patient arm that actually switched to camizestrant, by the time they switched to third-line therapy, just how we count this PFS2 interval has been quite debated, and we're kind of comparing apples and oranges in terms of lines of therapy. Camizestrant was associated with some toxicities, including the unique toxicity of ocular photopsia, which is light flashing. And this happened in 32% of patients, as well as grade 3 neutropenia was seen in 45% of patients. So additional analyses have been reported since that initial presentation, including the reporting of the PFS2 results, as was defined in the study, and by how the study defined it, the updated PFS2 results show a significant improvement in the Cami arm at 25.7 months versus 19.4 months. Whether this is a pathway to regulatory approval of camizestrant or practice changing, I think we can talk about it if there's time. But I think with some of the methodological issues with the study, I think we'll have to be thoughtful about whether patients need to have their treatments switched based on molecular changes alone. There are additional oral SERD combinations. So I wanted to highlight the combination arm of the EMBER-3, which included imlunestrant in combination with abemaciclib. When you're doing combination, certainly you're going to have the median progression-free survival improved to 10.9 months compared to 5.5 months of monotherapy. And we kind of the next few slides are again this is looking at patients who were previously treated with a CDK4/6 inhibitor. At this point, the median progression-free survival is 9.1 months versus 3.7 months with imlunestrant. And then looking at patients with and without ESR1 tumors, we tend to see a little bit of a higher PFS in patients with ESR1 mutations, but certainly a significant effect is also seen with patients without ESR1 mutations. So for the interest of time, I will move on. Anytime we're using combination, we're going to have more toxicity. This goes without saying. So in the combination, there was higher rates of diarrhea and neutropenia when the combination was used, with 86% of patients treated with abemaciclib and imlunestrant having diarrhea, and 48% having neutropenia. Moving on to another important trial that was read out in this year's European Society of Medical Oncology and further updated in San Antonio. This is another SERD, giredestrant. And in this study, patients with no prior chemotherapy in the advanced breast cancer setting, but prior exposure to CDK4/6 inhibitors were randomized to SERD plus everolimus versus standard of care endocrine therapy. Most of the patients received exemestane, but fulvestrant and tamoxifen were also allowed, with kind of bringing back an older targeted therapy, everolimus, which is an mTOR inhibitor. The prior CDK4, the most common prior CDK4/6 inhibitor was palbociclib. 47% of the patient in the interventional arm had received prior fulvestrant. 68% had visceral disease. And we see promising activity in the ESR1 mutated tumors with a median progression-free survival of 9.9 months compared to 5.45 months in the standard of care endocrine therapy arm. We also see activity in the intent to treat population with a median progression-free survival of about 8.7 months. The interim analyses of survival are still immature and currently not significant. And then breaking down things back down again, kind of this question of co-alteration is hugely clinically relevant as we treat these patients, and kind of similarly building on the findings that we previously reported in the EMERALD study early on in the presentation. Patients with co-alterations still benefit from SERD therapy. So just because you have a PIK3CA alteration does not mean that patients are not going to respond to SERD therapy. So again, kind of reinforcing that point, and continuing to look at that measure of endocrine sensitivity by prior stability with CDK4/6 inhibitor. These tumors tend to be more endocrine sensitive, so the median progression-free survival is 10 months for that patient population with the giredestrant and everolimus population. It does carry additional toxicity. Everolimus, as you all know, is associated with increased rates of stomatitis. So prophylactic dexamethasone mouthwash, which patients don't always love to use, is really critically important. Giredestrant was also associated with low-grade bradycardia events. What about elacestrant in combination with other targeted therapies? I think it's really important to look at the ELEVATE trial, which looked at different combinations of elacestrant with some of our currently approved targeted therapies, including everolimus, abemaciclib, and ribociclib. And again, this population is listed, and this is a population that has seen a number of prior therapies, so very much reflecting the population that you will see. And looking at the elacestrant plus everolimus population, we see a median progression-free survival of 8.33 months, and we see this consistent benefit across all subgroups, including those with PIK3CA mutations. When we add additional agents, certainly we do see additional toxicities, but there was no new safety signals with the combination, and there was no bradycardia or photopsia reported when elacestrant was the SERD that was used here. Looking at the elacestrant and abema data, again, we see a pretty impressive combination with a median progression-free survival of 14 months with benefits seen across all key subgroups. And the safety profile is consistent with either abemaciclib as well as standard endocrine therapy and elacestrant. Certainly, you're going to see a little bit more diarrhea and neutropenia, no bradycardia or photopsia. So in conclusion, I think that Elevate kind of further builds on the evidence that for patients that you might think might need combination therapy, that the combinations have demonstrated a good safety profile. And as we continue to mature these data, elacestrant potentially can become a very safe endocrine therapy backbone to be used in combination. Just kind of again, kind of summarizing the different studies that we have talked about here for the interest of time. I'm going to move through these very quickly, but certainly combinations are possible, and I think the Elevate data are quite promising for this. There are lots of oral SERD combination trials, including the ADELA study, which is looking at elacestrant in combination with everolimus as a phase 3 study. So this will be an exciting study that will generate additional confirmatory data about combinations that could be quite effective for our patients needing combination therapy in the metastatic population. So with that, I will stop sharing, and I really thank you for your attention. And if there's time, I'm happy to take questions.
Thank you, Dr. Lasberg. Very informative lectures and excellent presentation. Now time for question. Dr. Ahmed.
Thank you very much. Really very comprehensive talk. And sorry, it is a late time, but it is opportunity to be with us to ask you. Just we have patient with combined mutation, ESR1 and BRCA, and ESR1 with PIK3CA. So how to prioritize, especially for those with BRCA, PARP inhibitors or elacestrant? This is the first question.
Great. So you're saying your patient has a triple alteration, BRCA, ESR1, and PIK3CA. Yes, yes. I think in the population of BRCA altered tumors, germline.
Well, we have the two possibilities. The two possibilities: ESR, PIK3CA, or ESR will.
ESR and BRCA. Yeah, so for ESR and PIK3CA, as long as they have previously shown good endocrine sensitivity defined as stability on CDK4/6 inhibitors, at least for 12 months, I do prefer to start with the better tolerated options. I typically pick SERD monotherapy in that population. For a patient with a germline BRCA alteration, I do prefer to use my PARP inhibitors first, given kind of the data that we have with the PARP inhibitors, knowing that you can still come back to ESR1 alteration therapy, and then in the future if they have other alterations. I'm sorry, I'm not hearing the audio if somebody's speaking. Hello?
Do you hear me?
Yes, I can hear you now.
I'm so sorry. We had a technical issue. We couldn't hear your answer for the previous question.
You couldn't hear my last answer?
Yeah, we couldn't hear you.
Okay. So for patients with germline alterations, I do prioritize the PARP inhibitors based on the strength of the data. But in the absence of germline alterations, I think if they have a co-alteration of ESR1 or PIK3CA, as long as they have shown good endocrine sensitivity with their last endocrine therapy being at least 12 months, I think the SERD monotherapy is a good option for these patients based on the data that I showed.
And for PIK3CA with ESR1, you will depend on the hormone sensitivity. That means 12 months, or also other like disease burden will be in consideration for combination versus monotherapy.
Disease burden is a little bit less important as long as you are worried that they are going to go into visceral crisis very quickly. Our data show that, you know, the ESR1 therapy could be just as effective in patients with visceral metastases, as long as you're not worried that they're going to critically progress in the next few weeks. And they have shown that they have at least a year of sensitivity on prior endocrine therapy and targeted therapy, such as CDK4/6 inhibitors. I often have a discussion with patients. I say, you know, as a SERD is going to be better tolerated, better quality of life. We can start there. And if need be, we can always switch. I tend to review all the toxicities, and generally patients prefer the better tolerated treatment first.
Excellent question. Just I have one question regarding the ESR1 mutation testing. Does the exposure of chemotherapy prior testing can affect the result?
It tends to not. It tends to be associated with prior exposure and length of exposure to aromatase inhibitors primarily. So if you've had actually patients on fulvestrant therapy first line, they're actually less likely to have an ESR1 alteration. Prior chemotherapy tends to not impact that pathway.
So for those patients who had...
I'm sorry, go ahead.
Yeah, go ahead.
No, please.
Yeah, for those patients who already has ESR1 mutation and already received chemotherapy, and we know the result of oral SERD after chemotherapy, the efficacy is not that much. Do you have any subset of patients you will still consider oral SERD after chemotherapy?
So it again comes, it's a great question, and it has come up certainly in my clinical practice. It really comes back to whether you believe, based on the data you have seen from this patient, that they are endocrine sensitive. It comes back to that. If you needed to use chemotherapy first for whatever reason, first or second, they may still be endocrine sensitive. They just didn't have a fair try of endocrine therapy. But if they've been on multiple lines of endocrine therapy and you have chosen endocrine therapy in place of if you've chosen chemotherapy in place of endocrine therapy because of, you know, certain factors that led you to that path, and you're worried that they're not endocrine sensitive, giving them a SERD after chemotherapy is not going to have an effect. But let's say they had sort of near visceral crisis and you started with chemotherapy, calm down their disease, then absolutely, there's no reason if they have an ESR1 alteration that you can't use that pathway and target it. So it just comes back to, is their disease endocrine sensitive or not? I feel like that's the primary consideration. I've lost audio again. I'm sorry.
Do you hear me, Dr. Lusberg?
I hear you now.
All right. Satellite Symposium. Thank you very much.
Thank you so much.
I think we're going to move to the last session for today. This session will be about survivorship and quality of life in breast cancer patient. The last session will be chaired by three dear friends and colleagues, Dr. Najda Al-Haidan, a senior radiologist at National Guard Hospital, Dr. Hind Al-Malik, Dr. Hind, breast surgeon, and Dr. Huda Naimi, a breast surgeon at National Guard Hospital, Riyadh. And without further delay, we can start our last session.
Okay, no problem. Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon. I hope some of you are still awake to listen to this topic. First, I want to thank the organizing committee for inviting me for this very important event and share our experience with our colleague. Actually, the topic today is very important, as this talking about screening, which is important for patient and also strategically mandate that we have to shape the future of breast cancer in the world as well as in the region. What we will do in this topic, we will go through the barriers of breast cancer screening globally, and then we try to see how is it relevant to our region and especially in the Kingdom of Saudi Arabia, and also try to find some solution, evidence-based solution that can improve our practice. So while we are waiting for the presentation, let me just give you a introduction why this is very important. Before I joined Dr. Sulaiman Habib Medical Group, I used to be the director of breast cancer of the cancer control program, where we implement the breast cancer screening and also the colorectal screening. So whatever I'm presenting today, it's upon our experience. It's a true experience, and what we find barriers or challenges and what solution we did in practice, which really improve I remember when we start in 2013, the program, before I joined the program, it was like 7 months or 1 month, 1 year before I joined. They have only 1,000, only during 1 year was screened. When I left, it was more than 500,000 we used to screen yearly. So what we did, this is how we can solve the problem. You want me to give you the, okay. Can I have my hand back? written in the barrier of breast cancer screening. So why screening is important? Yes. It's starting. Yes. Okay. So you have this. Okay. Okay. Oh, it's running very fast. So why screening of very important diseases matter? We know that breast cancer is the most common cancer among female, and really it's quite the most burdened cancer globally. While we notice advanced in the diagnosis and in the imaging, in the treatment, this we cannot, and which is significantly improve the patient survival and outcome. These benefits are only can be realized when cancer is detected early. Screening has constantly been shown to reduce breast cancer mortality and treatment. Indeed, can I excuse me? Can I use my new one, because this is old one? Okay. Can we go to the what I did? Because I told Ahlam that please change that. Okay. Okay. Can we go to this? Sorry for this disturbance, but okay. Okay now. Okay. Okay. So there is definitely, I'm sure most of you read the report, that there is a reduction in the mortality above 20 to 40% in women aged 40 to 69 in countries where they implement the organized screening program. There is definite persistent gap exists between the availability of the service and the actual uptake. Now, the objective, as I said, we review barrier across the full screening pathway, awareness to treatment. We compare the global pattern to the Saudi context, and then we will identify the dominant barrier in our country and propose, as I said, solution. Evidence-based solutions. Now, what's the barrier? I put barrier in nine column, and this is start from the woman itself, woman herself, her barrier, individual own barrier, to a lot of health system barrier and policy gap barriers. This we will go through it. I try to be fast. Now, individual level barrier, what's her knowledge, what's her belief, what's her emotion, if she has bad experience of, or she listens to a lot of social media. The most universal pathological, psychological barrier is the fear of unknown, fear of diagnosis, and uncertain what's breast cancer, what will be the bad news after this. This is actually the most important barrier. Another low perceived of personal risk. I'm fine, I feel fine, I don't have family history, I don't have lump, so I don't go for screening. So there is misconception and illiteracy between the diagnosis and the screening. Most of the lady, they don't know. Screening means that you have nothing and you have to attend the screening clinic. And there is also a lot of misconception from the social media, from rumor about radiation and screening safety. Lack of awareness, I said, they don't know. And also there is a lot of guidelines, so it makes them a little bit confused. Now, especially now, we have a lot of, like 45% of our ladies are working, so there is issue with the work constraint, working female, tired, lack of time, whatever. You know that always lady prioritize her family issue than her health issue. So this is reported in most of the multi-country reviews, and about 20 to 45%. Now, what proposed solution? Definitely awareness. Awareness in different way, either direct communication, bring the survivors as the best ambassador, primary care physician who can give her advice, convince her, apply new technology. Now we are in technology era, so apply application which can get good information and even facilitate her to go to the screening center. One proposed, and actually we applied for 2 years when I was director of the cancer control. It's paid sick leave because of the lack of time. So when when the lady went to go for screening, we give her sick leave. So this was also good strategy. Culture and social barriers. You know that we are conservative. We used to be, but still until now we are conservative culture, and embarrassment, especially when it's not woman environment. There is also embarrassment. She wants to examine her breast or to do mammography or whatever. This is one stigma. Until now, stigma. Fear. It's not stigma for herself. She will be afraid of her daughters. They will be there. Her daughters will have also cancer. So this is one of the issue. And there is also afraid of the impact on her marriage if she's married. We have a very sad story where the husband leave the lady when she have diagnosed with the breast cancer. And fatalism, we have this. This is God will leave it. If God wants this, it will happen. Nothing will be changed. And there is no treatment for cancer, as if this is cancer death sentence. Why I'm telling you this? Because still we have a lot of late diagnoses. They see around them very bad story. Friend, whatever, either she died or the journey of her treatment was very difficult. This is why still this in their back of their mind. طبعا proposed solution, awareness again, and also female-centered care environment, community campaigns. This was picture of our campaigns. We used to do a lot of campaigns, not only in October, all over the year. Also, we bring the survivors. They are, as I still say, that they are the best ambassador to talk about their experience. And we used to take mobile in the women traffic areas, and also use the advantage of social media to send very reasonable, motivating message that this doesn't mean التوكل وليس التواكل as we most of our people do. This is also some of the campaign we used to do. We tackle them from the air, from the under the sea. We have a lot of, even we brought the mail to encourage them because the mail support is very important. Now, this is a new emerging barrier, and it's globally. Social media misinformation and conspiracy theories. They think that mammography induces cancer, the compression can spread the tumor. This is why this is run or promoted by pharma drug companies, you know that, and imaging companies to do this is. And now we have also new phenomena that lifestyle, alternative lifestyle. If you do lifestyle, yeah, we know that lifestyle have also reduced the risk of cancer in general, but doesn't mean this is the one. So now I can, and I hear a lot of influencers talking about lifestyle or hair per treatment. And the problem with this social media, it become viral. I'm sure a lot of you heard about this Switzerland stop the mammography and the screening, and biopsy can spread the cancer. So what is the solution? We should have a transparent site that can give really an independent, not really, can really give a clear information and guideline. And we have to let also now the doctors or the health worker talk about, not only the influencer, but to talk about, we cannot leave it to our own. Yani, I go and make a video or send message, but I don't have time. There should be organized system that allow these people who really know what's good information to be in the social media. This is also part of the also information we used to use it in our campaign. This is policy gap barrier. And unfortunately, until now, it's evident. And this is all over. Policy misalignment represent a foundational systemic driver underlying many of these barriers. Many. If there is no policy, well, I don't think everything will go smooth. So what happened? This is, I'm talking globally, not only in the Kingdom of Saudi Arabia. Lack of political or institutional willingness to prioritize screening. Until now, still we concentrate on the disease, not on the prevention. Although in the Vision 2030 there is prevention quite very important. Preventive screening, but still until now we are concentrating more of the disease, and also there is a lot of fragmentation of the service between the public and the private. There is also another very important issue, lack of insurance coverage. You know, now we have a lot of expatriates and also Saudi who work in private, or they don't have a place to go to for a treatment. So insurance, it's not only to do the screening itself, also for follow-up diagnosis. And there is lack, of course, of the centralized monitoring coverage, stage and of the disease and follow-up. So what's the solution? We should shift from the reactive, as we only concentrating on disease itself, to preventive centered national health strategy. We should have a screening, organize a screening program. We should put it as a priority. Very important to standardize the guideline, because there is a lot of confusion even between the professional about the guideline. And integrate screening, should be integrated screening target or KPIs within the primary care centers, and they are the main referral area. And this is, we noticed it in 2017, where we set KPI monthly will be shared with our minister, and you cannot believe how viral become the numbers. Yani this, every doctor, how many refer from the patient, woman 40 and above, and also the KPIs for the center itself. So primary care center is very important to be part of the important screening step. And also we have to work for mandateful insurance coverage for screening and follow-up. We are the people who work in private, we know what does it mean and what's suffering the woman here. Establish, of course, centralized registry and accountability dashboard, and align, as I said, all the people who involved in the breast cancer screening will be in same framework. Now, strategic barrier, access, availability, scheduling, access to care is very important. If there is no participation, even if the service is free, doesn't mean anything. So access to care is very important. either due to insufficient infrastructure, workforce also shortage, limited service, especially in the rural area, remote area, transportation difficulty, especially if you live in Riyadh. There's a lot of transportation difficulty, long waiting time, or improper or inconvenient scheduling also can also have a big impact. Lack of organized invitation or reminder to the screening time. This is also of course, there is now conflict areas where we can see in the region where they have war and this. I remember one year I went to Zaatari campaign, refugee campaign. I saw very bad advanced breast cancer there, and of course they don't know about it, or they know but they have nothing to do. Of course, the proposed solution, outreach mobile. This is, I can show you here our mobile there. We brought a mobile. We can go to the traffic area, women traffic area. We go there. We can go to the rural area. And also we established a screening clinic, women screening clinic in the shopping mall, in primary care, that they don't have also to wait for scheduling and referral to another place. Implement the invitation system and extend the clinic hours. Weekend, night. This is what we did with the Women Clinic. They work 7 days and also up to 10 o'clock. Digital reminder, I said, and of course there should be always the implementation usually on faces. There should be clear strategy how to expand the screening to cover the whole target group. Health system level, I think everybody of us know that there is workforce shortage and capacity limit. Shortage even of the skilled team, cancer team. Lack of physician recommendation. This is very important. Primary care physician or family medicine who should be the soldiers of the fight for this war to fighting the breast cancer, they think that it's not their business. So they don't even, they come the lady, they don't even bother to tell her that you have to do screening, and this is reported 23%. As I mentioned before, there's variable screening guidelines. Some people, they say start 40, some 50 annual, not annual, do, not to do, start with ultrasound, then mammo. This is all confusion. And of course, lack of organized national screening program. Also, this system should be not opportunistic what we have. And of course, proposed solution, expand with the workforce, bring more doctors, train the people who was not skilled. Should be guideline. We have guideline, unfortunately, national, but nobody use it, or few they use it. And patient also, you have to engage the patient with this, because they are also good to motivate the others. We should have a quality assurance performance. There should be dashboard for what we do, what's the result, what's the outcome. Otherwise, we don't know what's the situation of breast cancer in our region. And also, as I mentioned, primary care referral pathway is very important. Now, this is technology and digital infrastructure barriers is very, very important, very important. Why you cannot work in manual now. We should bring all the centers, all the primary care from the referral until the tertiary center both should be together. So what we have, globally, limited reliable high-speed network. You don't have network, or sometimes unstable network. And you know that when we do mammography is quite big size. So if you don't have good high-speed network, or you don't have a stable network, this will affect really the flow of the screening. We don't have until now unified electronic medical file. People, what happened in this primary care, people in the tertiary hospital, they don't know. Lack of centralized breast screening registry and also tracking system. Inadequate digital appointment. some they don't have even digital appointment. You just go, and this lack of centralized packs and for mammography, fragmentation of storage. In this region they have stored, this region they have stored, this region, all not connected together. And most of the places, they don't have what we call it special breast cancer screening solution, where start from taking the risk factor of the patient, know what's this, until you continue to see what happened with the lady when she goes to the tertiary center if need. So the proposed to have centralized packs, national centralized packs for archiving, and to deploy platform or solution for breast cancer screening. It doesn't work with the solution of the unified file. There should be a different, special solution where can go with the woman journey along from awareness to treatment. As I said, we should have a stable high-speed network across all the primary care and all the regions. And we should have automated abnormal result alert and recall system, national registry and dashboard for to know the performance, what we are doing, otherwise we don't know what happened. And of course, we can use the AI supported not only to read the mammogram, also to align our workflow. Financial barrier is very important, even in places where the screening is free, like here. And this is the cost, because the cost of the disease, treating disease, is unaffordable for any person, include now most of the health system is not affordable. This is why they want to detect the screen early, because of the big cost of the disease. So lack of insurance, very important, or if there is insurance, there is no adequate coverage that to cover her also with the diagnostic workup. Fear of out-of-pocket, you know, there is direct and indirect costs. Sometimes the indirect cost, it's more for the patient than the direct cost. Indirect costs, if she doesn't have really good coverage, what diagnostic follow-up. In 2025, there was a big report from WHO showed that more than 70% they suffering from the out-of-pocket costs, especially this after Corona crisis. Indirect costs, like she needs transportation, she needs the child is I finished almost accommodation. If it's in the rural area, she need to have the ticket to come to the tertiary center. She need the accommodation, all of these. So the proposed solution is very important. There should be policy or that there be full coverage for screening and diagnostic. And we can enhance with the other facility that we give her, support her with the indirect cost. Research data gap, very important. We don't have good quality, by the way, data. This is so we have limited resources for local good quality data, lack of infrastructure to conduct the research, lack of expertise, lack of registry-driven performance audit, lack of funding, very important. Bring company or even to have research from your hospital, usually they don't give you good funding. Of course, you have to have collaboration to overcome these challenges. Collaboration with well-established places where they do good quality study, increase and train the people who qualified to do the research, conduct regional research focused on the local needs. Now, in just one for the Saudi Arabia, what's the most important? Fear of diagnosis, very, 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 very high prevalence. Embarrassment, modesty, concern. Family, and sometimes family, they have also influence, fatalism, social media, here become very viral in our places. System, until now we have opportunistic screening model. Policy, until now, and prevention vision gap. Still, we have big gap. We have problems still with the digital integration, and we don't have centralized until now, very centralized screening registry, workforce shortage, and insurance follow-up gap. This what resulted that still until now we have high proportion of advanced cancer, stage 2 and 3, delay presentation despite that the screening is free, and culture factor misinformation amplify existing barrier. Now I will not go through this, I want to share with you what we did, but just to tell you what we did to solve the solution and the awareness. When we start, do you believe that we used to have this CD, and then we do centralized tags? This is our archive when we start. This was, do you believe? Yani the people who start, I don't know how they do. And then we have, this is our archive at the end. The fact we have mobile clinic, we wrote very nice, because we believe that also women should have nice place to be screened. We use this new mobile clinic and also the Well Women clinics, and even reading area to make it better. We used to start with manual, and then we created ourselves this cancer solution system. This is now whatever done even in Bisha, you can see it in the Riyadh area. Last, whatever we did until now, and I'm from the people who think I did a lot for the screening, but still, it's nothing. We should do more, and we should be together working for this. Screening is, I think, business and for everybody. Still, breast cancer is not solved. Still, we see a lot of bad cases. Barrier is cumulative. It's not only one. From awareness until the treatment, removing cost, as our case in the kingdom is not sufficient. Participation is still low, not more than 22. Last report, the paper I published, not more than 22%, 22 to 27% until now the participation. So uptake is very important. If you don't have a client, you don't have result. So you don't bring the people, still the cancer detected late. Policy, we should have governance, technology, and trust. Our people now in an era where they don't trust medical. Do you agree with me? They have a lot of confusion about medical and this. Okay, thank you. Yes. Okay.
Our next speaker is Dr.
Can I remove? You will remove.
And she will be talking about 5-year follow-up results for positive pregnancy
Assalamu alaikum. We need to go to the next one. Thank you for providing me the opportunity. As always, Nafisa is always inviting about this wonderful meeting. And I'm sorry I came earlier than Mariam, I believe, because I had some commitments, sorry. So I will try to go fast, so it cannot take a long time. We'll keep the eye on my timing. So today my job has been given like a 5-year follow-up results from positive trial. As should I go like this? Okay, yeah. So just a little background of positive trial, which is very, it's a very soothing to have this trial, especially for Saudi Arabia, because we have so many young patients. And it was always the questions. I'm here for 15 years, and I know that what we went through now, we have at least something that we can depend on it, and we can know that, okay, it's okay to give them opportunity to get pregnant. And we are covered also medical legally also. So that is a very soothing part, but still I'm very careful about selecting the cases. So let's go over a little bit about the positive trial. The hormone receptor positive breast cancer requires prolonged endocrine therapy. Now, more and more we are getting the drugs. We have from 5 years, 7.5 years, sometimes 10 years, like when untreated disease. I don't care if patient is tolerating. I feel like they should do that lifelong because so many cases come up. Whenever we stop the hormonal therapy, extended therapy, after 2 years, they come back as a metastatic. So my belief is if patient is tolerating, I continue with them. So pregnancy is, of course, contraindicated during the endocrine therapy. It used to be the same thing. We could never think that we can allow anyone to go pregnant and stop the hormonal therapy. And so young survivors frequently face the fertility outcome, especially we know that the ladies are getting more education, they are delaying their pregnancy, they are later, and the above 30, they get this. Now, what is the time? There is a pregnant breast cancer. Now, again, I have to hold off for 10 years, 7 years, when I can get pregnant. So that was a really difficult scenario. And especially in West, we see a lot these type of things because women have delayed their personal life significantly. So positive trial was designed prospectively assess the oncologic safety. And it was a phase 2 trial, and it was not the randomized one, but it was single-arm, prospective single-arm international trial where patients were enrolled from 2014 till 19, and stages were 1 to 3. Most of the patients were hormone receptor positive. A small percentage was also HER2 positive. Patients' age was 42 or below. Well, in our hospital, our fertility physicians don't want anyone above 37. They think that after 37, getting the ova is difficult. So they decline those cases who are above 37. And external control was soft and text trial. So what everyone knows, all of you are oncologists, you know that this diagram that 18 to 30 months of hormonal therapy as an adjuvant therapy, and then you give the washout period of 3 months, and then you continue to give them the opportunity to get pregnant. So which is a total of 2 years, which is including the 3 months, then in between time period when they have to get pregnant, deliver, and then after that they have to restart the therapy. And this during 2 years period, they encourage for the fertility therapy to get pregnant so they don't waste the time. So it was 516 patients were evaluable for breast cancer, 497 patients were evaluable for pregnancy-related events. For the same median age was 37. Stage 1 to 2 were 93.4% patient. You can see that very small percentage was more advanced, stage 3. And 62% received chemotherapy. So we all know that the younger patients, most of the time, lymph node positive, they all get the chemotherapy. And they have a more aggressive disease. So our tendency is more towards this thing. So here is the schema of the patients who were enrolled, and most of the patients were less than 35. You can see 34%, 35 to 39 years of age was 42%. So you all can see these things, body mass index, race, and previous births. You can see patients who were never been pregnant were 75%. And those who have one child, it was about 25%. Unfortunately, in clinic, I get the patients who have 4 and 5 children, and they are asking, I want to get pregnant. And then I don't support them because if they have an advanced stage, that doesn't make sense. Those who don't have, in our hospital, they don't give the opportunity to give those type of fertility therapy or things for patients who have more than 1 children. They just don't accept them. They give them only nulliparous or 1 child maximum. Even they are accepting now single ladies also. So as I mentioned that this is the repetition. Okay. So What is happening? Okay, this is the schema about the patients who were enrolled, and there is all the age, lymph node, patients who have a lymph node positive cases. You could see the 4 to 9 lymph node patients were also enrolled, but it was a very small number of patients. 5 were the one who had who went for the pregnancy things, and the stage of the disease, body mass index, and chemotherapy, and all were hormone receptor positive patients. This is okay. If you see that the prior treatment exposure of endocrine therapy was median was about 23 months, SERMs only alone was 42%, SERMs plus ovarian function suppression was 36%, and AI plus OFS was 16% patients. Here, the primary endpoint was for breast cancer events, local, regional, or distant recurrence, contralateral invasive breast cancer recurrence disease, or pre-specified safety threshold was 46 events. So first we have two data. We have a data which was about 3 years incidence when they looked at this, because they made soft text as a standard and they compared with those patients who were on positive trial. 44 breast cancer events happened, which was according to the threshold, so it did not exceed. And 3 years incidence was in positive trial was 8.9%, and in control arm, which was a soft and text trial, it was 9.2%. So no difference, is almost overlapping these curves. So there was at 3 years, we know that there was no detrimental effect, but interrupting the pregnancy, interrupting the hormonal therapy and getting pregnant. There was no difference in patients who got these interruptions. So later on in ESMO 2025, they followed up to 71 months and almost 6 years follow-up. And they did not observe excessive recurrence. Results were consistent with the initial New England Journal publication, which was for the 3 years data in positive trial. I can show you this thing, 71 months. What they did is they did the matching with the soft and text trial, but I don't know about the statistics, but there was a bootstrap matching method was used. And here, so outcome of 71 months median follow-up for breast cancer-free interval as well as disease recurrence-free interval, you could see that numbers are much higher. As we all know that the breast cancer patient, ER positive, later in life could have a higher risk of relapse, because initially we did only for 3 years. But later on, the numbers are higher, but they were matchable. They were not having a difference having a interruption or no interruption compared with the soft and text trial. So if you look at the disease recurrence-free interval, also 7.9 versus 8.5%, there was no difference statistically. And if you look at the 71-month median follow-up, some of the cases stand out in this thing. First of all, patients who had HER2 positive disease, there was a small percentage was HER2 positive. They did the best, because we all know that we have a very good therapy for HER2. And once they have a complete response, they hardly get the recurrence. So they are the one who did 71 months. They have only 7.1% risk of relapse. Patients who have a lymph node positive, overall, when they have a 4 to 9 lymph node positive, their relapse was about 23%. And patients whose tumor was more than 5 centimeters, their relapse was 20%. So here numbers were less. So it is hard to interpret, but I think we should be cautious about those patients who are locally advanced and those who have a multiple lymph node positive, about applying this thing on those patients. We all know that those patients already have a high risk of relapse. So this is the same thing which I was mentioning. Higher recurrence, we all know that more than 4 lymph nodes positive will have a higher risk of relapse. More than T3 diseases will have a higher risk, and they are very small in number. So it's difficult to interpret with the positive trial with comparison with the soft and text trial. So the strength and of these group is not negative, low event rate was seen. It was comparable between soft and text trial, and interpretation was reassuring. Even on 71 month, basically 5 years. 1 to 3 lymph node positive, they have slightly higher risk of relapse, but it is slightly higher risk of relapse is both in soft and text trial, as well as the patients who did the interruption. So it was no excess risk by interruption, but those patients have a higher risk overall. Patients who have more than 4 positive lymph nodes, they were much more higher events and small numbers. We have to be careful about implementing this thing on it. So in the same thing is less than 2 centimeter, 2 to 5 centimeter, and more than 5 centimeter. Do I have a time? Okay. So basically, now we have to look at this. Does pregnancy increases the risk of recurrence? No increase in the breast cancer events was seen, both in 3 years as well as 5 years. They were comparable with the soft and text trial, and landmark analysis was reassuring, except patients who are very high risk, not because they interrupted the hormonal therapy, because they have a tendency to have a higher risk of relapse. So if you look at the pregnancy outcome, was 76% achieved the pregnancy, and 422 were live births. 82% resumed the hormonal therapy, and median time to restart was 26 months. Breast cancer-free interval similar between 2 groups. Now signs of early distant relapse triggered by pregnancy, and important reassurance for the patient's counseling. Now, what is the negative part? What is the concern is because these trials were done before the era of CDK4/6. So where we can put these things, because we have a patients now, high risk, we give them CDK4/6, and is it going to, you need to interrupt? I don't think so. I will consider completion of their CDK4/6, whether abemaciclib or ribociclib, and then they should go for this thing. And most complication, what happened is the hypertension and low birth weight. Babies were seeing birth defects of 1.8%. So important limitation, as I just mentioned about this thing, longer follow-up we definitely need it, especially patients who have a very high number of lymph nodes. I will be really cautious about offering them this thing. I don't offer anyone who has more than 1 child. I don't offer them, and if I see the patients who have a multiple lymph node, I discourage them. Because still it is a phase 2 data. It is not the randomized trial. Because whenever we know that when the patient selections are done in the clinical trials, they are very much biased, and we see that most of the patients were very early stage. Very small number was a higher stage. So endocrine therapy interruption is reasonable in selected patients, and some selected, and it should definitely be joint decision. You should not implement, or I at least don't implement on patient. If those who are interested, I discuss with them. If those who say that I don't want it, I never push them. So stage 1 to 2 patients, disease, node negative, limited nodal involvement, more than 18 to 24 months endocrine therapy, strong desire for the pregnancy, multidisciplinary counseling, and definitely documentation, so you don't get the lawsuit. Okay. More than 4 positive lymph node, large tumor, very high grade, those who need the CDK4/6. And you know, we get the feel, right? The patients when we are giving the neoadjuvant therapy, or we are getting how the patient behaved, or how the final path is. When you get the feel, no, this doesn't make sense, I don't offer them. So this is it. I think it's my repeat. So anyone has any question, I'm happy to answer because I'm sorry I had to leave early. So, right. So what we do is patients, anyone who comes a new breast cancer patient and she has a desire to get the pregnant, we send them immediately for oocyte preservation. And while we are doing the workup, we those patients start and we start the LHRH agonist and our fertility. We have a pathway for fertility. The new patient comes in the combined clinic or individual clinic. We just pick up the phone, talk to them, we activate the pathway. Within 2-3 weeks, the patient is seen within a week, and the workup, they start doing it, and we give them opportunity, maximum 1 or 2 trials. So they can start doing this thing. In the meantime, we have all workup done, and also the chemotherapy infusion zone or everything is aligned, and we start this thing. Our fertility physician, what he does is he gives tamoxifen and 5 milligram Femara along with the Clexane. He requests, we order, and we do it.
Yeah, thank you, doctor, for this presentation. Do you think that now in the era of adjuvant CDK4/6 inhibitor, would you maybe change your way of thinking around the non-limited node-positive disease, that maybe 2 years of CDK4/6 inhibitor and endocrine therapy would be enough and the patient could go for pregnancy?
So as we mentioned, that this is the limitation of this trial, right? But I think that patients who are they have a time period, right? 18 to 26 months. I think it's a rare case. I might get it after 3 years, and then if it is university, we can go for 2 years. But in our institute, Abhima secret for very strong high risk patients, right? And patients who don't fit the Abhima, those patients get the RIBO. So I will be little reluctant for Abhima cases because Abhima cases are very high risk. They have either N2 disease, more than 5 centimeter tumor. So personally, I'm not comfortable talking them. I try to really convince them and screen them that how important is being having a child mother. So if she's completely nulliparous and she's single and she just don't have very much insight, I try to sit down with her, teach her, and we have a very good nursing. So mashallah, they also, I have a limitation of language. So I sit down with the nurse and what I say is convey the message.
Thank you.
For the kind of so I'm asked to talk about this cancer. So I'm going to go about overview of breast cancer, details about each. So as a basic concept in oncology, we know cancer is no technology. So any cancer patient or any cancer, they are having this technology. If they have this abnormal in their gene that happened after birth, before this is correct, and this is most of the cancer that we see. About 2/3 cases. 1/3 patient, they have what we call familial or hereditary cancer. So familial, you will see cancer that runs in the family, but it requires specific. So this is a familial cancer. Inherited cancer
cancer, where we have a cancer that only values and we identify specific genetic mutation that can be exposed to these cancers. And when we look to the most recent advances in the treatment approach, huge advances in the treatment, one of the major successful studies that we have introduction is identification of the cancer specific or sensitivity gene. So in cancer, I think this is the typical referral that we see. Most of the referral that we encounter either only or rest or other. The reason for this, these are the most common tumor malignancies diagnosed, and it's also the most studied cancer that is associated with hereditary breast or colon cancer. Still, we do see some rare tumors like carcinoma or syndrome, pancreatic cancer or other disease like also represent a minority of. So why do we need to do genetic testing? I think the classical thought about genetic testing is that you are trying to estimate the cancer risk and to come up with screening recommendation. This is true, and this is still represents major part of our work. However, with the recent advances that we have, more understanding about genetic mutation, we start to utilize this information not only for cancer assessment. Now it helps us in the prognosis, we use it as a predictor for certain therapy. It also helps us to personalize our approach regarding the prevention and screening, and also very important items in the therapeutic intervention and the precision therapy. One of the most well-known success stories is the BRCA gene. So BRCA gene was identified almost 10 decades ago. First, it was identified as a tumor suppressor gene. Then with time, we start to know the association with the breast and ovarian cancer. Then we start to understand that prophylactic surgery might work on those patients. Then in the last few years, it's come as a part of therapy. Specific therapy comes to patients with BRCA mutation. So we used to treat with BRCA metastatic setting. Now we are testing patients to receive therapy in the adjuvant setting. Not only this, this information has also translated into other types of cancers like ovarian cancer and pancreatic cancer. So this just to shed some light on the importance of underlying genetic testing and also the aim of population that is by. So in the clinic, especially for breast cancer, this can help in the treatment decision for the medical oncologist, for the surgical oncologist to guide about the type of surgery, the need for contralateral surgery, also radiation oncology. This is for certain medication, for example, TB medication. The radiation oncologist might avoid radiation therapy because this would increase the risk significantly. And also it helps us in the decision of the preventive decision and also to plan survivorship plan for those patients. Again, what we discussed at the beginning is applied for the breast cancer, which are already because 1 to 10% that is negative, and we have the rest are siblings. These are the genetic gene that is established to be associated with breast cancer. It's different genes with different risk of developing breast cancer, and we have discussed some important points. So this is the paper that looked for more than 113,000 women, and what they looked to they tested all these patients with a comprehensive panel with they tested many genes at the same time, and they come up with the most important gene that is associated with breast cancer. So BRCA1, BRCA2, BRCA2, all these mutations are associated. But also we learned that are some of these genes that we thought that it's associated with breast cancer, like NBN or MRE, it actually does not increase the risk of breast cancer. Another important thing that we consider when we encounter patients with something important, the influence of communication. So the percentage of patients with the medication and how many people express cancer. The higher the percentage, the higher the interest, and we will be more aggressive of prevention and in terms of screening or for risk reduction services. there are certain genes that people will address. So the intervention might be less aggressive, and we have to know those genes and those who will follow by average risk population, except if we have some. Another important point that we take into account in the counsel the patient is aggressive population. So, like a for example, we do see now families that they have a private medication for the private cancer, that's not protected cancer. So not each medication that the state so we have to come up with individualized approach. We take the classification of the medication, the cancer, the highly that we see the and based on that we can come up with a treatment for surveillance implementation for our. In the past, we used to rely on multiple models. So we function tests. So there are risk models, criteria, certain population, like Ashkenazi Jewish population, they have higher tendency of blood mutation, pathology like negative breast cancer, and important point is whether genetic test will affect them. So we used to follow these criteria. It's very reasonable. But we understand the time that following this criteria, we are missing about 50% of patients who might have underlying genetic mutation, but we don't think the testing criteria, so we are not testing them. So what we have adapted, and this is published from the NCCN guideline for the ANIMA group, we published the screening documentation. So we recommended anyone with breast cancer with age less than 50 to be tested, and anyone with age 50 or more, they will be tested. There is a history of other drug associated gene. Anyone with negative breast cancer are eligible for testing, and anyone that the result of the CAD is of PARP inhibitor, they can be tested. So this is our recommendation for the genetic survey there and so what type of testing? This is very important. As I have shown, there are multiple genes that affect this post breast cancer. So you see sometimes that there are testing for the BRCA1 for BRCA2, and you know that from this if we just give the test for these two genes, we can miss some of the patients who have underlying genetic mutation. So we do recommend to have the family test. It's almost the same cost. It's faster and it's less syndrome specific. The problem with this and testing that I can discuss with you is sometimes you can find something in the genetic testing that is not associated, cannot be explained by the patient cancer or by the family testing. So in Saudi Arabia, there has been multiple studies that tested the effects of BRCA1 and BRCA2 mutation. The largest was done by Dr. Affair, and it showed that if you test for BRCA1 and BRCA2, the percentage is around 10% of patients. However, we did our study that was published 2 years ago. We tested beyond BRCA1 and BRCA2, so we have a full genetic testing. We found that this percentage increased to 60%. So there are multiple mutations beyond BRCA1 and BRCA2 that can be tested, and this is what we adapt in our practice. So when we get the result of the patient, these are very important, and this is what our genetic counselor will do with the patient. So there are three possibilities. So either the patient has no underlying mutation, which is the most common result, or they will have a pathogenic or pathogenic variant, which can execute the patient cancer, and we only act on pathogenic and likely pathogenic variant. Sometimes we give the patient the result of VOS, which is very significant. So the patient comes to you with a BRCA gene mutation or changes, but the classification of this mutation is VOS. So the explanation for this that is there are changes in the gene, but we don't know if it's leading to bad patient management, or should we act on medical care or surgical interventions or medical therapy. What we do usually is just for those patients. We do the classification of the gene. Surveillance like imaging is fine, but we don't based on variant specifics. As I mentioned, one size does not fit all, so we have to individualize our approach and qualification similar. One of the most important the underlying mutation is very so the risk of cancer with the BRCA1 mutation, the gene that is considered as intermediate risk gene, but the cancer risk increase with age. So this indicates that we have to be more vigilant as we follow the patient and we grow with age. Gene is the most studied gene associated with breast and ovarian cancer. As you can see here, there is a wide range of prevalence. This is reflected by the population study. And not only they are at risk of primary breast cancer, they are actually at risk of secondary breast cancer, and they are at risk of other malignancies like pancreatic prostate cancer. Also, we have to keep in mind the genotype-phenotype association. So BRCA1 tend to be triple negative breast cancer. BRCA2 tend to be hormone receptor positive, but we do see patients with BRCA2 and they are triple positive breast cancer. We do see patients with BRCA1 and they have hormone receptor positive. So it's variable, but this is the common phenotype. Another important thing that we take into consideration when we follow the patient in the clinic, and this is the base of our implementation. So for BRCA1 and BRCA2, as you can see, starting from the age 25, the cancer risk starts to increase, and that's why we start our screening implementation by the age of 25. If you look to the ovarian cancer, in contrast, so the BRCA1 area, they are at risk of ovarian cancer after the age of 30. So in those patients with these individuals, we recommend to have the prophylactic surgery between the age of 35 to 40, compared to BRCA2, where we can wait sometimes up to the age of 45 or 50. These are the screening recommendations for BRCA1 and BRCA2 mutation. You might see different guidelines, but MRI starting from age of 25 and adding mammogram from the age of 30. And there has been always a question about the role of prophylactic surgeries compared to surveillance. And it was an area of debate until the last week where there has been a publication in the GCO, which is the biggest oncology journal, and they compared surveillance. So they have two groups on it. Group they are opted for surveillance, following the UK guidelines for surveillance, versus the women who opted for prophylactic mastectomy. So what they found that in terms of survival, actually there is no difference in survival. So the risk of cancer might be increased with the patient who opted for surveillance, but the outcome of the both group were similar. Less anxiety in patients who underwent prophylactic surgeries. And when they did the prophylactic surgery, actually they found 9 patients with underlying hidden malignancies, and this indicates that we must do full pathology report for those with specific. Now, is this a final? I'm not really sure, as 8 years follow-up is enough. I think we need to wait for more that to see, but at least this is something reassuring to me, at least for my patient, when we counsel them that still we can do good job with surveillance screening if we are not keen on prophylactic surgeries. Mutation is one of the most aggressive genetic mutation that we see. Unfortunately, their lifetime risk of cancer is almost 95%. And in those patients, with those families, I push always for prophylactic mastectomy. The surveillance for those patients usually start from the age of 30 by doing MRI. But actually, what we do for those patients is still the exceptional if we do whole body MRI as a part of the screening, because this is the only way to detect cancer, because we can develop cancer from the brain to the throat. Some of our patients, we might come with a syndromatic appearance. So ET mutation is one of the classical examples, Cowden syndrome. We do have it in our clinic. We have 3 or 4 families. They come with a classical cutaneous manifestation, but also they are at risk of breast cancer, which is about 25 to 50%. In those patients, there is no strong rule to do prophylactic surgeries, but intensive surveillance is a very reasonable achievement. So this is to summarize to you the gene and the syndromes associated and their lifetime risk. One of the recent genes that we start to understand more is the BACP2, which is the aggregation of partner localizer of BRCA2. Actually, it's almost like BRCA2 in terms of behavior and risk of breast and pancreatic cancer. So to summarize, I think assessment and testing for hereditary cancer predisposition syndrome should be part of any cancer patient management. We need to do effort to try to improve access to tests in appropriate time. Multiple gene panel testing is preferred over single gene testing. As we discussed, the personalized approach is the preferred way in terms of screening and surveillance. And this is a multidisciplinary approach. I guess I conclude. Thank you very much.
I'd like to welcome before you Dr. Fayez Rabia, Chairman of the Reproductive Medicine and Fertility Department, former head hospital, Basic National Drive, PR. I thought will be about the question, does IVF increase the risk of breast cancer? Or is not?
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everybody. So we're talking about, is there any risk of IVF treatment or medication on a breast cancer, on a future breast cancer, newly diagnosed breast cancer or breast cancer survival? Why the concern exists? Because IVF involves short-term exposure to supraphysiologic estrogen levels. Estrogen is known to stimulate the breast tissue, raised concern about a potential link to breast cancer risk. What about the role of infertility itself? So infertility, nulliparity, and delayed childbearing affect breast cancer risk. And these factors often confound IVF-related risk assessment. So by adjusting for these factors, it will remove most observed risk differences. Infertility problems can be cured through use of several methods, including assisted reproductive techniques, surgery, medications, and intrauterine insemination. Many studies, especially retrospective cohort, have long focused on the future effect of these assisted reproductive technologies in women undergoing these treatments and their offspring. Parity and increased breastfeeding may reduce some subtypes of breast and gynecological cancers. But with regards to research on the effect of IVF treatment, this method can increase the risk of developing breast cancers. Commonly used ovarian stimulation agents encompass selective estrogen receptor modulators, such as clomifene citrate or Clomid, and gonadotropins injections, which are typically administered alone or in combination during the follicular phase of the menstrual cycle of an assisted reproductive technology treatment. Their physiological effect within a single cycle of ovulation induction has been reported to be equivalent to that of 2 years normal menstrual cycles in terms of follicular count achieved and the estrogen concentration reached. With these rapid rates in gonadal hormone levels, the direct and indirect effect of these agents on estrogen-sensitive tissues, especially breast tissue, and consequently on an individual's risk of having a breast cancer remain unclear and of significant clinical importance. Breast cancer is one of the most common malignancies in the world, affecting 1 in 8 women. Although nulliparity is a known risk factor of a breast cancer, Prolonged exposure to estrogen and progesterone is known to also increase the risk of developing a breast cancer. So, with an increasing number of women having infertility treatment involving the use of ovarian stimulation agents to conceive, the long-term effects of ovulation-inducing drugs on the risk of a breast cancer is a matter of great importance. A lot of studies conducted to assess the association between ovarian stimulation agents and the risk of a breast cancer in infertile women. So what does the evidence show? Large cohort studies and meta-analysis show no overall increased breast cancer risk, no consistent or causal association demonstrated, risk estimates similar to the general population. It changed all our thoughts. So one of the most common randomized meta-analysis, risk of a breast cancer in women treated with ovarian stimulation drugs for infertility. It was a systematic review and meta-analysis. The conclusion, in this large evaluation of women treated for infertility, the use of ovulation stimulation drugs such as Clomid and gonadotropin used individually or in combination was not found to be associated with an increased risk of developing breast cancer. The use of gonadotropins injections did not prove to be associated with any increased risk, but further study may be warranted to further investigate the influence of the cumulative dose of gonadotropin on breast cancer. Although this study provided reassuring evidence, it highlights the need for further register-based studies with the potential to span longer follow-up periods. Another meta-analysis on the possible association between in vitro fertilization and cancer again concluded the same. The meta-analysis suggests there is no significant association between IVF treatment and cancer risk. Another infertility treatment of infertility and the risk of a breast cancer among women with BRCA1 and BRCA2 mutation. It was a case study, and this is risk factor. The conclusion, the result of this study suggests that the use of fertility medications does not adversely affect the risk of a breast cancer among BRCA mutation carriers. Given the small sizes of the exposed subgroups, this finding should be interpreted with caution and confirmatory studies are required. So all up-to-date meta-analysis, randomized controlled trials, and even the case report shows no association. So another review of breast cancer, the conclusion was the same. So who are the special populations? BRCA mutation carriers, breast cancer survivors, IVF and fertility preservation can be safe. Use of letrozole-based stimulation when indicated. This is a protective measure. So what are the professional society guidelines or guidance? American Society of Reproductive Medicine and European Society of Human Reproductive Endocrinology showed no evidence IVF increased the breast cancer risk. Oncofertility guidelines support individualized care. Shared decision-making is recommended, of course, between oncology department and reproductive endocrinology department to specify or highlight the risk factor for each patient, to individualize the treatment plan for each patient. Though there is no evidence-based supporting the risk of a breast cancer, but still we have to individualize each patient plan, patient-specific plan. Clinical take-home message regarding this subjects, IVF treatment does not increase breast cancer risk in the general population. Underlying infertility factors must be considered. Counsel patient with a clear evidence-based reassurance. What about the effect of IVF treatment on breast cancer survivors? The primary concern, safety of ovarian stimulation and IVF after cancer. Does IVF treatment increase the breast cancer recurrence or mortality? Does estrogen exposure during stimulation pose a risk? Is IVF treatment safe in ER positive or estrogen receptor positive disease? IVF treatment or assisted reproductive technologies after breast cancer does not increase recurrence of risk. No worsening of overall or disease-free survival reported. Evidence consistent across multiple cohort studies again. Standard IVF increases estradiol levels transiently only, and this will not affect or not increase the risk. Short-term exposure differs from chronic estrogen exposure. No proven dose-response relationship with recurrence. So we have to differentiate between IVF treatment and hormonal replacement therapy. It is different. When we are talking about hormonal replacement therapy, we're talking about estrogen and the progesterone therapy for a long time of period for those postmenopausal population or those who developed iatrogenic menopausal state due to chemotherapy. So we have to support them with with HRT to protect their bones and to provide the physiological estrogen levels. But we are talking about IVF treatments. Role of letrozole-based stimulation. Aromatase inhibitor supplemented protocols reduce estradiol levels, preferred in estrogen receptor positive survivors, no increased recurrence observed in available studies. American Society of Reproductive Medicine, European Society, and Oncology Society support ART in survivors. Individualized counseling is emphasized again. Shared decision-making is essential, of course. IVF after breast cancer is generally safe. Letrozole-based protocol preferred in estrogen receptors positive disease. Close coordination with oncology is mandatory. Thank you.
Thank you, Dr. Ahmed, for this interesting topic. I have a question, and I will start with the question Dr. Devin. What do you advise for a patient who's young with triple-negative breast cancer, BRCA positive mutation, and low burden metastatic disease, who is very keen to live better?
Okay. So this is actually, a complex situation, because we know triple-negative metastatic disease, the survival is very poor, and the prognosis is poor. And on those patients, usually the treatment mainly is systemic chemotherapy. So there is no targetable therapy that can be used, and it's in either weekly or every 3 weeks. So it's really will be difficult to have a space or time for them to get pregnant if they have a triple-negative breast cancer.
For the patient they are keen to have kids for sure, they are undergoing right now very induction. What would be the best protocol for screening them during the induction and the pregnancy as well?
Usually for these ladies, before they start, we do, depend on the age, of course. If it's 40 and above, we do first mammogram and then we do MRI. MRI is very important. We follow them with the MRI. This is what we usually do for them, yeah. No. Yes, our ultrasound or automated ultrasound is going. It depends. Sometimes we don't also now, and I know MRI is quite safe, but there is ongoing reports. It's not really very safe totally. So if it's really not indicated during pregnancy, we don't do it but ultrasound or automated ABIS, it also can be used. Yeah.
Actually, trials can be 4 to 6 trials. All the evidence suggested close monitoring for those patients, but there is no increased risk of breast cancer. Are you talking about survivor or the general population risk? So for survivals or for newly diagnosed breast cancer, for a newly diagnosed breast cancer, we're talking about fertility preservation cycles. So we have to be cautious. For the general population, there is no increase. The risk will be as same as the normal population. So we're talking about IVF medication, like gonadotropins, and which increase the estrogen levels, but in a transient manner. I showed it is different from HRT, hormonal replacement. The chronic exposure, of course, will increase the risk, but the cycles of IVF treatment, it is a transient elevation of estrogen. Yeah.
So the best way to go with this is goes by cancer specific gene. So sometimes we have patient who comes with breast cancer. So there is a panel that include all the genes that associated with breast cancer. Now, if we have an overlapping history, sometimes they can have different spectrum of cancer, not only breast, or does not match, for example, the hereditary breast and ovarian syndrome. We can do more expanded panel. So all these depend on the history and based on the patient risk assessment. But I would suggest to go with the cancer specific panel unless there is other indications.
My last question to Dr. Germi. My understanding actually is the more and the longer you are testing for cancer genes, the less incidence you will find because you already mapped a good part of the population. Do you think we are there or not yet?
I don't think we are even close to that because I don't think we are, first there is a limitation to genetic testing. Not all individuals who meet the testing criteria are tested. There are a lot of challenges in the, let's say the referral hospital or even secondary hospital to offer this test. And even in the tertiary care center, I don't think referring the patient to genetic team or genetic assessment is really a major part of the assessment. So I think it's still early. We need to have more and more awareness among the oncologist and among the primary care physician about the role of genetic testing and trying to do more testing for our population.
Thank you for the speakers. For Dr. Muhammad, rather than the family history and known genetic mutation that the patient have, the age by itself, cut-off point age, if to refer the case to you as for genetic testing. I mean, cancer in young patient. So any cut-off point age group that we have to consider this.
So I don't think the age only is an indication for genetic testing. Now, over the last 10 years, as you are aware, Prof, that there is a global increase in the early onset cancer, not only breast, colon cancer, and other type of cancer. And there is no really clear explanation for this global increase in the cancer in young population. We don't expect there is a germline shift that can cause all of this, but it's something need to be considered. However, in common cancer like colon and breast, I would still stick with the criteria for age. Definitely, if I have a young woman with 25-year-old or 30 with breast cancer, I would still do the genetic testing. But for common tumor, and adhering to the age is important. For rare tumor, for example, someone come with pheochromocytoma, all these patients should be tested regardless of the age.
Questions for Dr. Hayat. And Dr. Hayat, we have one patient. She fall with the positive trial presented by Dr. Kauthar. She was hormone positive. She interrupted the treatment after 2 years. She has no children, and she went for IVF. She came after 3 months with metastatic disease, and she passed after just 2 months ago. My point: do you have any collaboration with the? When you receive patient escaped from her hormone therapy, reach to you for IVF, any? What we do in the oncology tumor board or multidisciplinary meeting, do you have like communication to select your best patient for IVF, especially for those kinds of? And the last question for Dr. Faten regarding the impact. Now we applied the national pathway breast cancer, but as part of the model of care. So and almost implemented 3 years ago, and really practically we saw the number of screened cases increasing. Do we have any impact study about the impact of this implementation of this protocol to for detection rate? Thank you.
For our institution, we have a shared care with oncology. We have a fertility preservation clinic for those patients referred from oncology. We have a connected system, so we don't start IVF treatment for walk-on patients, and no. It is a well-controlled procedures. It's under control. So that's why we have a fertility preservation clinic.
Regarding the positive trial, they gave hormonal treatment for 2 months and then they stopped and they allowed the patient to get pregnant. Was it assisted pregnancy or was it spontaneous? I think we need to look at this very carefully, because we know those patients, they did not complete their adjuvant, so they are at high risk of recurrence if they stayed. And I heard a lecture by Prof during last San Antonio, that the patient who did not get pregnant, actually, when they stopped tamoxifen at 2 years, they really develop very quick recurrence or progression of their disease. While those who get pregnant, there was no evidence, the incidence of recurrence of their disease was less by Prof. Partridge. So she said, we are not advertising for pregnancy, but this is what what did they notice from during that trial. So we have to make sure, was it assisted, definitely in 100% of the cases, or was it spontaneous pregnancy?
Yes, do impact according to the Cancer Saudi registry. Last report 2020 and 2019, there is more detection for stage 0 and stage 1, and also less for the late stage. But what we are not happy about it, that still the late stage is quite large because of the as we said, the service is available, it's free of charge, and the participation is low. But this is what we are looking. And according, that for the WHO initiative, that they are looking for reduction of mortality 2.5% yearly until 2040. They want to reach this, that we will reach this. But yes, we have an impact. Actually, we've been called for the minister and also the Crown Mohammed bin Salman. They celebrate with us this result. But we hope that better. We can do better. I tell you, because still we are high-income country. We can do better. But the problem is still the opportunistic time, and there is no policy that make this screening is a mandatory. Okay.
Thank you very much for our moderator for this excellent session. By this, we reach to the end of our meeting. Thank you very much for all our distinguished speakers and moderators. Thank you for our physical and virtual attendees, and thank you for our supporting team here, Mohammed, Jason, Hanan, and the rest of the group. And hopefully we'll see you again, inshallah, in another meeting. Good night. Assalamu alaikum wa rahmatullah.
You are very good.
Assalamu alaikum wa rahmatullah. Thank you all for joining these 2 days of this event. We appreciate your time and effort. We'd like to inform you that we will be sending you an email to evaluate the event. The email will be coming from Al Faisal University. After that, you'll be entitled or eligible for CMEs. So please pay attention to your inbox. And once you close this session, it will guide you to the registration for our next meeting. So please make sure to register there and share it with the friends. Have a nice evening. Wassalamu alaikum wa rahmatullahi wa barakatuh.